Did you say your speaker?
Yeah, testing mic. Okay. Let's just see if it's working or not.
Yeah, do that little thing where you make it beep.
I don't know that little thing. How to
Where you,
make it beep. I don't know what are you talking about?
You slide it up a little bit and let go and it beeps.
Oh, okay. This?
Yeah, that seems to be working.
Okay. Good morning. First day of school, yay. Hey, Alexa. Just waiting for Ashley Smith.
I'm here.
Oh, you are? Okay. Very good. I'm getting feedback. Why am I getting feedback? Is that from the speaker? Maybe it'll go away. Okay. I think it's better. Okay. Good morning, everybody. How's everybody doing? So before we get started, I think it's good to talk about clinical, since clinical is tomorrow and it's a new experience for a lot of you, right? I know like half the class is doing the VSIMs, so you know you're gonna benefit from the pioneers of us who are going in, you know, highway to the danger zone, right? No, not really. Sometimes I feel like the hospital's the safest place because that's where you have the PPE and they're doing the screening, right? It's not like the grocery store, which I haven't been in 6 months, but you know, that's just me. But I'm really looking forward to clinical, but then I had to have a little reality check, right? Because this is the new normal, where clinical isn't the 12 weeks that you used to get. In terms of, you know, on site, you're only getting 6 weeks of clinical, so it's half of it. And, you know, I had issues before with pediatrics only being 3 weeks, you know, that you didn't really learn everything about peds in that time, or NICU and nursery and labor and delivery. You know, there's so much to learn and so little time. And if we look at it in that aspect of like, how are you going to learn everything? You're not, right? So realizing that, realizing that the Board of Nursing kind of looks at this semester in the content we're covering in terms of these all being specialty areas. So when you view it as a specialty area and that you're getting exposed to each of these areas, right, and gleaning content and information. So they look at it as the majority of you are going to go into adult ICU settings as new grads, to hone your skills and to, learn procedures. And, the vast majority of you are going to go to adult med surg floors, whether it's in ortho or, respiratory units and those kind of areas. And, and then there'll be, actually, when we go to peds, there's quite a number of PMI graduates in pediatrics. So, they hired a new grad right into NICU, an excellent PMI graduate, went right into the NICU. So where before, in the past, a lot of new grads might not have gotten hired into these specialty areas. Now we are seeing it more. So, there you go. There's two sides. There's two aspects to this, this semester. But if you start to feel like, wow, we're covering so much content in such a little time, let me just, reaffirm that for you. Yes, you're going to feel that way. Okay. It's a lot of reading and it's moving right through the lifespan. So, true to its name, we're moving out of the long-term care, that kind of, okay, somebody's been diagnosed and we're looking in terms of, primary, health prevention, tertiary, secondary. So, they've had the stroke and now we're taking care of them in long-term care and we're helping them rehabilitate. Well, now this semester, it's acute care nursing, right? You're going into the hospital, into that acute care setting. And we're going to look at, from the very beginning of birth, from preconception, actually, through the birthing process and postpartum, moving into neonatal care and pediatrics and the adult world. So, and then a little psych, as icing on the cake there too. So, because that's part of your clinical rotation, is that psych rotation. So, we have a new clinical instructor that Mrs. Edwards knows this person. She's worked with her, and now I'm spacing on her name, because it's something cute. It's not Amy, because it's spelled different. Who has her? It's Mrs.
I think it's Tiffany Gray.
Tiffany, yes. And and then I saw two different last names, and one is her new married name, and she hasn't gotten to change her name with the Board of Nursing. Gallic or something like that?
I think it's Granite.
Granite, Granite, like yeah, that's. So has she sent to you your patho information? And are you guys also, that team, are you also meeting and getting your name badges tomorrow?
Yeah, we are.
Mm-hmm.
Okay, at 6 a.m. also?
Mm-hmm.
She still said 5:45 in the parking lot.
Right, okay, because it's 15 minutes before clinical starts, yeah. So yeah, so then all, is there 6 in her group or 7? What clinical team does she start with? 1 or, do you know? I don't have clinical schedule in front of me.
Group 1. I think it's group 1.
Okay, is there 6 in that group? Oh, there's only 5 in that group, right? Okay, so that's nice. So there'll be 11 of us in the morning getting our pictures. And I figured during that time we'll be doing our pre-conference, going over paperwork and kind of looking at, the expectations for the day. Okay, so for my clinical, I also have specialty areas assigned, GI lab and cath lab. And so I'm going to try to give everybody 1 week of observation paperwork in my clinical group. So that even counts as 1 week then that you won't be doing patient, direct patient care on a unit. So you get 1 week in ortho, 1 week in peds or PICU, and 1 week in a specialty area. So, trying to make it, the same experience for everyone, and then having to deal with the fact that I don't have you guys all in peds for 3 weeks, because that's kind of a loss for me. We talk about, identifying losses and changes in our, the new normal here with, this clinical experience. Hey, we'll take what we get, right? Because then I had to also realize we don't know the new things that we're going to be, you know, the PPE, you know, you got your mask, you got your goggles, right? We're tracking what patients' rooms we're going into, monitoring, screening ourselves for any new cough or fever. You know, I think coming into this new semester, we should celebrate some successes too, right? I think when I look at some of the issues other school districts are having with re-entering, you know, the things that have been on the news with the U of A, for example, right? We've had some successes. I think you as students have done an excellent job being compliant with procedures on our campus, with, you know, taking precautions, with critical thinking. And we haven't, you know, trying to give you those heads up to, you know, be careful so that we didn't have any, you know, surges or anything on our campus or cases on our, you know, we didn't. So I'm just so happy about that and happy that you got through getting checked off on your skills last semester. So, you know, I think that's a huge success and something that we want to just continue, right? Constant vigilance. Always be aware of situations, aware of your own practices, and not doing touch contamination, right? I think it's different now than it was, you know, back in March. When we first got pulled out of clinical, this was, you know, a novel virus. And what does that mean? You know, it means scientists haven't studied it, don't know all of how it's communicated, right? They don't know what are long-term sequelae of people having the virus, if they can get it again, if, you know, they've had all of these studies now being constantly reported on for the last 6 months, right? So we know a little bit more about it now than we did then in terms of it being droplet, masks being effective, but not touching your face, right? Good hand hygiene, and that theoretically surfaces that are exposed, right? That you could touch those surfaces, and if you touched your face, you could, you know, theoretically catch the virus in that way. So, you know, just being very aware of that when you're in the clinical setting, that anything, you know, you touch the elevator, consider your hands contaminated, right? At TMC, they're just allowing visitors to come back. Just yesterday, it was on the news. So, you know, just knowing that that's that many more people who are going to be in the environment. So as long as we're cautious and, you know, practicing good infection control measures, you know, keep yourself safe, right? Any questions about that or other concerns? Is everybody clear on patho being the APA format? I think approaching patho as a student, what I would do first is go to Lippincott, go to the point, look it up there. Look at the scope of the disease, okay? Look at how does the disease present? What are the signs and symptoms of the disease? You know, kind of define the definition of what that exemplar is. And then looking at how many people are affected by it every year, how many new cases, kind of that epidemiology background of it in terms of the scope of the disease. What does it look in milder forms? What does it look at the worst case, you know, what is the mortality rates every year with that disease? What are complications and other factors associated with it, right? And then once you've given kind of that definition, that scope of the disease, then move into medications and treatments and maybe surgical procedures and, you know, different aspects of the disease in terms of that. And you can put headings in your paper addressing each of those bullets on the patho that's in the instructions for your first page. And then from there, I go into teaching aspects and, you know, course of the disease, and then maybe follow up in teaching, you know, patient teaching for home. So kind of approaching it in that way. Make sure you know, we're not using WebMD or Mayo Clinic, you know, things. It's okay to use websites that are for medical professionals, but not patient, you know, just lay people. We want, you know, professional journal and textbooks and websites, you know, your Lippincott source. Okay. Most of these exemplars, you're going to be able to get enough information out of Lippincott and your textbook. So don't just Google. Make sure you're citing your sources in the body of your paper so that any statements that you're making in your paper, you're defending with your references, and then give your alphabetically listed reference page at the end. Nice little cover page on the front of it, right? And you're all set.
Miss Erickson,
Mm-hmm.
for your group tomorrow, is there like a specific spot in the parking lot that we're meeting?
Yeah, there's a bus stop. The shuttle bus stop would be a good place to meet. There's a light there, so if it's still, yeah, the sun should be coming up by then, but we'll meet there.
Thank you.
Yeah, you'll see we're early enough so that we usually park kind of in the front part of the parking lot and go there. And then we can just walk across, it's not too far to walk across campus to security to get our name badges. And then from there, I'm going to be walking you into your different areas, you know, we'll hit the ortho tower first, and then we'll go to GI lab, and then we'll hit peds, and then I'll take the last person over to cath lab, and then swing back around, and really want to kind of focus on passing meds in the ortho and the peds areas, because that's, you know, to me, that's going to be your only experience with giving medications, right? And maybe the adult women, you know, but usually in NICU and in L&D and then in psych, sometimes the nurses have you get some Pyxis access and do some psych meds, but not so much as in peds and ortho. So just kind of having that, you know, trying to make the most of our clinical experience. No pressure, right? I know those 12-hour shifts are going to go by fast. You know, we break them down. They're really just 3-4-hour shifts mentally, you know. You got to pace yourself. You got that 7 to 11, 11 to 3, and 3 to 7, you're out of there. Of course, we're going 6 to 6 even, so even shorter for us. So, you know, same kind of thing. You'll get report. You'll just focus on your one patient. We used to kind of have students go with their nurse and go into all the rooms so that you could kind of see your nurse doing your assessments. Because of coronavirus, we don't want you in all the rooms. We want you just focusing on, so you'll go in, meet your patient, stay, do their assessment, do their vitals. Have you gotten your user ID and password for Epic? Yay, good, okay, wonderful. I was worried about that because I hadn't seen those emails going out or anything, so. And everybody's finished your CBTs, so you watch the videos on Epic, and we can go in and create your list, and then you'll know how to access the active orders. That's kind of the important things is know. So if you right now you're sitting here and you're like, oh, I don't remember those videos, they're still available to you. So tonight, you know, you could just take one more look through. So you know how to create a list, you know how to pull up your patient's active orders, and you know how to look up their medications and their labs. Okay, meds, labs, orders would be how I would prioritize. And then any extra time reviewing the flow sheet and how you document in the flow sheet and the progress note. But I think DocuCare has prepared you guys. You've gotten more DocuCare than classes that I've had previously. So I think that's going to really benefit you. And then with the VSIMs and documenting for VSIMs, that's going to help you when you go to clinical. And then getting your first assessment on your patient in the morning, getting that entered on the flow sheet, so that you want your complete assessment done by noon. So you're going in, you're questioning your patient on their understanding of their medications, if they have any cultural concerns, you know, what is their support, you know, do they seem anxious, you know, doing all those extra, you got your head to toe assessment that you're going to be putting in to Epic, but then you have your paperwork, right? and kind of review that, because there's questions on there about their religion and, you know, family situation and teaching and learning needs, that you're going to be developing that rapport and doing some of that, you know, history and questioning with your patient and their family. Okay, and identifying teaching needs. So in that clinical paperwork, you're making sure that you have 4 significant positive findings. So if heart sounds are normal, right? So they have a strong S1, S2, no murmurs, right? Those are just normal findings. So you're looking at the cap refill being 2 seconds. You just don't want to put less than 3 seconds, right? If it's brisk and immediate, or if it's 2 seconds, you know, being specific with how you're documenting those assessment findings. Here's a tip, and it works. When you're filling out your head to toe assessment in Epic, it gives you have those, you know, those areas like in DocuCare that you have to check the boxes and fill out. While you're doing that, take notes on your assessment sheet for your clinical paperwork. One, you know, so that it's being accurate and consistent between, and then you're not trying to think back, what are some other findings that I can document? The answers are in Epic, right? If you just follow along. So is their color pink, skin's warm and dry? What's the Braden score? What's their pain score? You know, as you're filling it out there, fill it out on your clinical paperwork. Okay, we can talk more about those details tomorrow, but kind of get you thinking, right? Here we go, we're back into the groove. Okay, any other questions about clinical? Are you bringing your lunch? Are you going to stand in line and get stuff at the cafeteria? What's the plan?
Bringing it.
Yeah, that's what I'm going to do. I think I'll find a patio outside to sit and, you know, get some fresh air during that time, get a break from the PPE, right? Might want to think about some kind of, you know, how you're going to be comfortable in your mask all day too. Make sure your ears aren't going to get too sore, that kind of thing, you know. Kind of think it through and plan. Do you have your own goggles? Okay. Very good. I'm sure there's something I'm not thinking of, but we'll figure it out. Okay, so I'm going to go ahead and pull up the PowerPoint. Let's look at Nursing 234, our class here.
I have a question.
Yes.
So do you stay with everyone, or where are you actually, since we have so many different units?
Right, yeah. I mean, obviously I can't be at all places at once. I'm not that good, right? I can only, as good as I am, I'm just like you, I can only do one thing at a time, right? So
Okay.
we've got to prioritize constantly as nurses. So yeah, like I said, when I drop you off in the morning, you know, I'm going to, as I enter, you know, as we enter that west entrance, ortho towers first, going up the elevator, dropping off 2 students in ortho. And then, you know, so I'll have you with your nurses, you'll be getting report. And then I'll have another student going into GI lab, and then we'll go to peds, and one student will be in PICU and one will be in peds. And I'll just make sure the nurses know, and you all have my cell phone number. So that's how we communicate. If you've got something going on and you need me to run over there real quick, you text me, and I text you back saying, you know, I can't be there right now. I'm giving a med in peds, and then I'll come, if your nurse can wait 15 minutes, I'll be there as soon as I can, you know, like if a patient needs pain med or something. So I do my best with trying to communicate and just run from one area to the next. The students, then once you're in GI lab and cath lab, really you just kind of shadow that nurse, and it's an observation area. Now, once we get you guys signed off on IV starts, okay, Mr. Gerhardt is going to look at, you know, doing IV fluids and bolus and IV starts with you, you know, in these first few weeks, so that when you go to GI lab and when you go to cath lab, you can help start IVs. Won't that be fun? But you basically shadow those nurses, and, you know, other than, you know, that first time you start an IV, I'd like to observe and get, you know, check you off in clinical. But yeah, it is a challenge for me, because I'm going to have to be running. Before, I've just been in peds, PICU, in like the children's emergency room, and that was a challenge enough. to go back and forth and give meds. But I had a bigger group too. So yeah, it's not too far from the ortho tower from pediatrics.
Okay, I have another question. Do we get check off also in clinical for every skill?
You don't, okay, if you have not been checked off on it, you don't do it in clinical.
Yes, but if we have
Skills
been
that you've
checked
been
off,
checked off, yeah, once you've been checked off in lab, you can
Mhm.
do it in clinical. The first time you do it, your instructor observes you.
Okay, so so if we have to give meds every single time, the first time you will be there.
Right. First time you give an IM flu shot, I'll be there with you. After that, if I say it's okay for you to do it with your nurse, you can just do it with your nurse. If your nurse is busy, we like to help out the nurses. And, you know, like if the patient's waiting to go home, call me. And if I'm available, I'll do the flu shot with you, even if I've seen you do it before.
Okay.
Okay.
Thank you.
Communication is key, as always, right? Communication's key. Come on, open. Okay. Can you all see this?
There's like a black box in the middle of the screen.
Okay. Let me try it again. So how I'm going to do this today for today's class. First, we're going to talk about the class and the expectations. And then, why is this not coming up? Okay. And we'll take a break after we talk about the class. And then we'll move on to reproduction. And then we'll look more about stages of the pregnancy and assessment of, we have prenatal, antepartum, postpartum assessment and care. Okay, so now can you see my PowerPoint?
Yeah.
Good, okay. Come on, there we go. Okay, so welcome to Nursing 234, acute care nursing across the lifespan. Okay, so here's how we have to get into this, okay? So everybody together, get your arms ready, okay? So off to your left, okay? We're gonna say this together to kick it off. Acute care nursing across the lifespan, okay? So we wanna think about from birth to death, right? We're gonna talk about Alzheimer's and, you know, everything from the very beginning to the very end. So not only are you going to get all these different exemplars, but you're going to be applying your knowledge of developmental levels and family-centered care, right? All the aspects of the different stages of life. So I bet you didn't know this about me, but obviously I am the OG, right? Did you know that I'm an original gangster? Obviously from this picture, right? So this is me with my kids at the fair. I feel like, you know, as you get to know me, I don't talk about my kids a lot because they're grown up now, you know, and they're on their own and they're out there working. But it was a little stressful for me last semester because they're both essential workers. My son works at a coffee shop and my daughter is an assistant manager for produce, the produce department at a grocery store. So they're both out there in the public and working, and but they're great kids and they're, you know, nice people. So, you know, and they're happy. So isn't that what all parents want for their children? you know, and of course, I think, I was a peds nurse for 30 years, from 1985 to 2015. During that time, I was able to take advantage of TMC paying 100% for my master's degree. So, when you get that reimbursement for education and things, take advantage of that, right? We always talk about you as the student being a lifelong learner, and, you will experience that. Things change in healthcare. You always want to stay current. You always want to be learning. And because of that opportunity, I'm able to teach you, right? And it was more than just educational reimbursement. They paid for books and tuition up front for University of Phoenix. So I was really fortunate, because, you have to have opportunities in life, right? Without the opportunity to do something like that, you don't go on and achieve those things. So when you get the opportunity, you want to make the most of it. So take that opportunity now, this semester, right? Continue to work hard, make the most of every day right now, focus on your own learning, because this, you have all these resources right now available to you. So I know we got a lot of other responsibilities, we all do, but I give you permission right now to make this about you for the next 16 weeks. You're going to learn a lot. Okay. So make the most of it. So like I said, this is across the lifespan, right? I like to say, kids, and I'm not the only one that says this, kids are not just little adults, right? They haven't gone through the developmental phases that adults go through. So kids are not little adults, but adults are big kids. And you guys, I see that some of you are going off camera now so that so that your bandwidth is working with the PowerPoint. That's fine. Okay. When we come back and I'm asking questions and everything, turn your camera on. Okay. We're going to talk about the word of the week is coming up. Okay. So I'll just put that little dangle, that carrot there. I bet you're all wondering what the word of the week is. And we'll talk about that, and it covers the camera issues and other things. Okay, so thinking in terms of kids not being little adults, but adults being big kids, right? So all of us go through certain developmental phases in our life. And so you'll see adults that then kind of can regress, right? They get where their family's not there. When we go into clinical now, there might be people who haven't had family members being able to visit, and they could, go back to that trust versus mistrust, or, different developmental stages can kind of become issues again in life. So like I said, we're going to be looking at this whole course. We're moving from just looking at healthcare promotion aspects, right? And more of that long-term care with a very stable patient, to now in a patient who's acutely ill. So we're in the acute care setting. We're integrating more critical thinking, prioritizing care. We say the answer is always airway, because if you don't have an airway, you're not moving on to your neurological. That was a final exam question last semester, right? And a lot of you, because of it being a stroke patient, you were thinking in terms of getting that initial neuro assessment, but you can't miss out airway, because if the patient's not breathing, you can't, you have to deal with airway first. So integrating critical thinking and care while incorporating those health promotion aspects across the lifespan. So anytime that you're interacting with that patient, you're always doing education, but this is more of the acute care focus. So this course, and this is out of our syllabus, right? So read through the syllabus really carefully. That's my contract with you in terms of what we're learning. I think it's helpful as we go through the course to kind of go back to that corporate outline and go back to the syllabus and say, hey, are we meeting all of these objectives? And you'll see that we've really carefully looked at the different concepts and how we're making sure that we're always incorporating nursing process. And I think as a student, sometimes you might feel that's a little repetitive, because it's like, okay, we're learning this exemplar, we're learning the assessment findings, the priority diagnoses, what are the interventions, evaluating care. It's like, it's kind of always the same thing over and over again. but that's exactly what we're doing in terms of providing care to patients. So yeah, nursing process, when you see that in the corporate outline, that's exactly how it's outlined, that we're learning this concept. If it's reproduction, we're learning these exemplars, if it's, postpartum hemorrhage, and then you're learning the nursing, how does the nursing process, how is that applied to that exemplar? So looking at you being at that, I like this intermediate novice level, right? 3rd semester. So you're not brand new novice. Now you're the intermediate novice. So you go from acute care nursing across the lifespan, and next semester you're looking at a more challenging patient, and then 5th semester is your critical care patient. So each semester kind of builds in terms of complexity of the patient that you're addressing in the area that you're going to. So that it's kind of nice to have that vision and that overview of where you're at, where you're going, and how our nursing program is laid out. So you're at that intermediate novice level, applying nursing process while providing safe and evidence-based, holistic, patient-centered care, right? I think that's a big sentence, but as you break it down, we've always focused on safety. And we think about those cues and competencies. And, when we look at, have you seen in the student handbook that mandala with each leaf of the mandala, being some of these core competencies that we're teaching you in the nursing program? Patient-centered care, evidence-based practice, the lifelong learner of the student, wanting you to flourish as a student. And the knowledge and the skills and the attitudes are on there, right? Teaching you that professionalism, that role of the professional registered nurse. So looking at safe, evidence-based, holistic, patient-centered care, right? The patient and their needs are always the center. It's not all, we're not coming in and saying, I'm your nurse, do things my way. We're saying, what do you need? What are your goals, right? Setting those goals with our patient. And then, looking at, of course, this semester, really focusing on lifespan. It doesn't mean as you move forward that you're not going to have pediatric exemplars. You will. We're always looking at different lifespan issues. Think about those patient need questions, right? How would this exemplar be different in the newborn, in the pediatric patient, in the elderly patient? So we're always incorporating lifespan aspects into our program. But this semester, that's really the focus. So you're going to demonstrate competent performance and integration of your cumulative nursing knowledge, the skills and the attitudes that reflect quality, safety, and accountability, as well as judgment and decision-making in the provision of care in the sim lab and in your clinical practice. So we're going to do, I kind of put this in my own words. You'll notice the syllabus is the hybrid format, right? So I think it's a little bit confusing when you're like, okay, we're online, right, for class. But this is a synchronous Zoom class. It's like we could be in the classroom right now, right? So I know there's challenges to being home on the computer, but if you were in the classroom, there would also be distractions in the classroom, right? Because people are, fidgeting around or getting up to use the bathroom, or, they're texting each other secretly, or they're on their laptop doing something and you're paying attention to what they're doing in front of you. So approach this as, yeah, it's hybrid, okay? It's not just online where you're on there doing a self-study kind of thing and I'm just facilitating it. I'm right here, okay? I want you to feel like I'm as accessible to you as if I was sitting in that office and you were coming in to ask me a question, okay? Text me questions, chat, stop me if you have questions, and let's make this more interactive this semester. I'm going to be calling on you more. I'm expecting you to come to class and to stay in class, okay? You can also stop me or start chatting if you need breaks. I'm going to really try to look at every 50 minutes, getting that 10-minute break and then coming back on the hour and, you know, having this be more of a real classroom setting, okay? So we're gonna do the combination of synchronous Zoom. I put asynchronous lecture because we might do that, it's, you know, with the holiday or something like that. You have simulations planned with Mr. Gerhardt. Each of the sims, each semester you also go up by a simulation in that lab. So last semester you had the 3 sims. This semester you're going to have 4 sims. You're going to demonstrate your skills, student participation, right? Lab time provides video demonstrations, small group discussions, virtual sim of skills. And this course provides you with the opportunity to apply your skills that you've learned in the classroom in the lab setting within that simulated environment supervised by qualified health professionals. That's me, you know, with my 30 years of experience. Well, 35 now, but so notice we're just saying the simulated environment, but you are getting 6 weeks of actual clinical environment also. So that's, you know, this is the hybrid syllabus. Okay, so outside hours. If you're thinking, boy, it seems like we've got a lot of reading, we've got a lot of outside assignments, you know, I feel like this is a part-time job just doing my homework. You're right, it is. With the Board of Nursing, when you look at the breakdown of this 8-credit nursing course, you got 24 hours per week that I'm supposed to, you know, be like keeping track of how many hours, right, is looked at for outside hours. And I wrote down, I had a little notepad here somewhere. Where did I write it? Here it is. So if I figure about every week, okay, so if you're doing about 3 hours of reading for lab or watching lab videos or looking over procedures for lab, right, about 3 hours a week for lab. And then about at least 6 hours of reading in Nursing 234 with the different chapters, about 6 hours. If it takes you about an hour to get through a chapter or so, and then 6 hours for your clinical paperwork, and then 9 hours for outside class assignments like the prep use, study guides, interactive tutorials. And if you get those done, you know, like a team project or something, if you get that done a little bit less than 9 hours, then you'd have more reading time or something like that. But I figure that's about right, you know, and that's about your 24 hours a week of outside work. Okay, so that's a lot of hours on top of going to school and on top of the other outside hours in your class. I bet if we added it all up, it doesn't leave a lot of time for any extra stuff other than sleep, if that, right? So, and then taking into account that some students are going to take longer for some of that stuff. Some are going to finish it in less time maybe, but you know, that's how we kind of have to figure it out to meet the Board of Nursing recommendations for, you know, our contract with them in terms of hours for the program. So I think a lot of times students will say, what do I want? Or you're giving us this work, or you're giving us this amount of reading. And there's only so much control I have over changing curriculum, right? This is a contract with PMI in the Board of Nursing, and I just have the responsibility of facilitating the punishment, right? No, the learning, right? So I think sometimes I don't want you to feel like I personally am putting this work on you, okay? We're in the same boat doing this work together, okay? And then this is just the contracted work between the Board of Nursing and PMI. I'm washing my hands of it a little bit, but you know, I don't want to feel this perpetual guilt trip of teaching, right? So the outside hours consist of your textbook reading, your studying and learning content, and reviewing for quizzes and exams, completing your homework assignments such as prep you quizzes, individual and team projects, writing papers, practicing skills, and conducting additional research and contributing to, so that you can contribute to your discussion posts in Blackboard. I know it's a lot of work, and I appreciate your work. I appreciate your commitment to being the best nurse you can be, to learning all you can, to taking on the challenges of being a nurse. But that whole, you know, I can't impress upon you enough that it will be worth it, that the reward you'll get from being a competent, great nurse, you know, and having people appreciate the great care that you're going to give it's going to be so rewarding. You want to be the best nurse. You want to know your stuff. So, you know, it will be worth it. You'll make a difference in people's lives. So you can have such an impact on people. You know, I think about how nurses are really the workhorses of the world. You know, I mean, nurses, I think we work harder than anybody. And it's great to work side by side with people who share that commitment and that passion. Okay, so I expect you to come here and to be present, you know, to be attending, to actively participate in discussions, contribute to the ideas, ask questions, help me out when I'm struggling for the right word, right? Actively participate in the facilities procedures. And, you know, like if you have things that you see that we're doing that you're questioning, right? Be part of it. Be part of the problem solving in making our program better. Participating at the hospitals that you're working at and patient care activities, and work productively in your groups. Okay, I think we keep ourselves accountable by putting your names on your slides, letting me know if there's an issue with communication between teams. And in this, and you'll see as we move through the syllabus, there's only 6 outside class assignments for like team and individual work. And, you know, I've done that because I kind of cut back on those points. Last semester, I think you had 10% of like weekly assignments. And so that was 10% of your grade, you know, that you got. If you work as a team, usually you're giving me good quality work that gets higher scores. So this semester, 6% of that is outside work, which on the positive end, you don't have as many outside projects with that. So you know you need to demonstrate each lab skill correctly. You get 3 attempts at that. It's a little, I think this wording is a little bit confusing because if it says if you're unable to perform the skills after the 2nd attempt, but you know you get 3 strikes. You'll be required to repeat the course. But we want you to have that 77% overall and pass all the lab skills, pass the math skills. But we want you to aim higher because I'd like to know that you're really understanding the majority of the content that's being covered in the course so that you'll continue to be successful in the future as you're building on that knowledge that you have. So competently performing your skills, complete the course in its entirety with a passing grade. Okay, this is just right out of your syllabus. Okay, so the word of the week is netiquette. Did you get an email from, or I know we were supposed to cover it in class. Did any of you receive an email about netiquette?
Yeah, we got it.
Okay, did you already watch this video? It's very short. And hopefully this goes ahead and plays. Do you see it playing? Is it loading on your screen?
The black box again.
Ah. Okay, let me go ahead and pull it up here and then we'll. How are we doing for time? You guys want to go ahead and go ahead and take your break while I'm pulling this up because it's just about 10:02. 9:47. So come back at 10:57, okay? You guys hear me okay?
Yeah, we did. Thank
Okay,
you.
good.
breakfast.
Yeah, can I have a piece of toast? Okay, is everybody back?
Yes.
I don't see Romance back yet. Romance, are you coming back? Okay, we'll go ahead and we'll watch this video. We'll learn about netiquette. No, I've never heard of netiquette before now. From Techopedia, huh? 5 tips. Be polite in all written or verbal communication because your instructor is an overly sensitive person. Make sure you are easily seen and identified. We like to see your faces on camera. Avoid distractions. Do not get on class while driving. Present yourself professionally while on camera. Be appropriate. Don't lay in your bed. Arrive on time. Be prepared. Stay the whole duration of the class. Okay? So that's just kind of a fast little review, but it's really important. Okay, guys. Here's how I'm looking at this. Last semester, previous semesters, when this pandemic was new, we wanted to be lenient. You know, we wanted to be understanding of what we were all going through. And I think for the most part we were, right? We tried to be understanding when things came up for students. But now we really want to make sure that we're being very professional. And I think there have been times that students maybe knew about an appointment or knew about a conflict with children's schedules or something. And, you know, during class, I mean, you've seen it during class where a student will like say, oh, I forgot, I have to leave early because I have to be at campus for this, or, you know, those are things that I want you to really think about ahead of time and email myself and Miss Severson if you're going to be missing any class time, any absent time. Think ahead, okay, and notify us beforehand. Don't interrupt class to announce to everybody, hey, I got to leave now, you know, or expect me to be reading chats and things during class because you know on something that you should have communicated beforehand. Okay, we're going to be just trying to reinforce those, you know, our professionalism in the program as we're adjusting now to this new normal. You know, we're going to be on a hybrid. We don't know how long we're going to be, you know, teaching classes online, you know, in Zoom, and, you know, and as we re-enter with small groups on campus and look at, you know, how we're doing that safely. So, you know, this is going to be a process, you know, until we get a vaccine and, you know, we don't have to worry about surges in cases coming back with flu season in the winter, right? We can have our best flu season ever. Here's my approach to it. We're all going to wear masks and we're going to have less flu cases and less coronavirus cases, right? So we'll make that our new goal. But at least that's my new goal. So, you know, more details of those 5 key points, you know, being polite, right? When I think I'm guilty of this also, okay? That initial email, you know, hello, Hannah, how are you doing? I wanted to make sure that you realized that your post was late for this and da 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 da, right? Or whatever. And then you email me back, yes, Ms. Erickson, you know, I realized at this time I had forgotten this and blah, blah, you know, right? But then we kind of start to go, oh, and by the way, and I might not be as, because I get rushed because time, you know, and I think, oh, I just want to quickly say, okay, thanks, you know, instead of maintaining that professionalism. What do you think? I think that's probably okay, as long as that initial was addressing the person and everything, to kind of have that then a little bit more informal back and forth to finish the discussion. But making sure that we're always, you know, being very polite in what we're in the emails. I haven't had too many issues with that. I think we just have to be really careful because written communication, sometimes the tone of it can come across in a way that we didn't intend. Okay. I always like it if it's on the weekend or after hours, if the student says, I realize that this is after hours, right? Or also if you're aware that you're missing things in your clinical paperwork, to send a message to the instructor saying, I didn't get to my client needs or this kind of thing. Because otherwise I go looking for it, or I'm concerned that, you know, like you didn't know that you missed it. So if I know that you already know that and you communicate that to me, that helps me understand what happened.
Miss Erickson?
Yes, Lily.
So this little thing that you have pulled up, it says that we have to wear our uniform.
That is being clarified. Thank you. Good catch. You do not have to wear your uniform, but you do have to dress in like business casual attire. Okay. So they don't want pajamas. They, you know, right. They want you covered, no short shorts, no revealing tops. Right.
Okay.
So
basically, like, as long as we're dressed appropriately.
Everybody looks good today.
Okay.
Okay. Yeah. And let's hold each other accountable too. Okay. I think that's always good practice. Yep. So yeah, being respectful, following, you know, making sure your camera's on, you're in an appropriate setting. You know, we've talked about lighting before where, you know, somebody, it's kind of interesting, isn't it, when you have a student that kind of has that backlighting and they look kind of, you know, like they're coming out of the shadows. You know, if you can't see their face. And my biggest concern is when you do have to go somewhere and you're driving and you're on, you know, I feel like you could be distracted with your driving. That could be really unsafe. And I feel like you're getting credit for attending class when you're really not being very present if you're driving. So don't do that. Be in a space where you can safely pay attention and expect that I could be calling on you at any time. Okay. To me, if you're leaving class and you're not notifying your instructor and we see that you're not there, you're being dishonest. You're trying to take credit for minutes that you're not actually in class. I don't think anybody here would do something like that, but just so you know, that's not okay. Yeah.
Miss Erickson, with
Yes.
that, I mean, when it says a space where you can safely pay attention, I mean, as you know, I have 3 kids at home. So like, you're not going to dock me for my kid who's sitting right in front of me with her headphones on. Ask me a question, I have to answer it.
Right. So just make sure that if you're going to have a side conversation, just turn off your camera so that it's not distracting to other people. Make sure you're on mute, you know, so that we're not getting any, and you haven't done that, you know, you haven't been interrupting class in any way. Right. But there was that, okay, so side, oh, and no eating on camera. So that's a big thing too. And we have had that where, you know, somebody's been eating or getting food in the background, you know, and that can be distracting. That's the thing is we just, you know, it's my job to make sure that I'm facilitating that, you know, a good learning environment for all of you. And I don't like doing the police work, to be honest with you. That's not why I went into teaching, but so I appreciate all of your help with this.
Or can we not just turn our camera off? I mean, we are at home. I don't really understand how it's super.
What was that? Did somebody have a question?
Why can't we eat? I don't understand how it's distracting to everybody.
Well, some people don't have as nice of eating habits as others.
I mean, if they're muted, they should.
Oh, and the camera, well, they're not supposed, well, you see, at any time I could be calling on you. And then if you're putting your camera on, you got your mouth full of food. That's why Matthew, that's why I'm going to be good about taking breaks, those 10-minute breaks. So I feel like, you know, a break's coming. This is, you know, if we were in the classroom, you wouldn't be allowed to eat in the classroom. So we're maintaining those same rules. And while you might have not had an issue with it, we have had other students say that they had issues with seeing people that were eating. So like I said, I don't make up the rules, but I can see, like in the classroom, you know, allergies are a huge concern. So you wouldn't want to have food in the classroom that somebody might then have an allergic reaction to. Okay, and know that, like it said here, PPS points could be deducted for that. Okay. We spent enough time on that? I'll go back to the PowerPoint. There we go. The word of the week, netiquette. I don't know. Anybody know if that's in Webster's? I don't think it's in Webster's. Okay, so like always, you know, notify us, like I said, notify us of any absent time, including late arrivals or early departures, okay? Let us know why. Same attendance policy. Ms. Severson will be tracking your attendance. When it gets to 5% or 10%, you'll get notifications. If you miss 14 days in a row of class or 15% for absence, it could result in termination. Clinical absences, it's really important that we attend all of our clinicals. I know Ms. Edwards does have plans in place if you miss clinical due to exposure to coronavirus or getting sick, because we absolutely do not want you to attend if you have any of the symptoms on the you know, assessment page, the preclinical page, symptom, you know, symptom screening. So
Actually, I have a question.
yeah.
Are for clinical, because I know to go onto campus, we have to do like the pre-screening at home now. Do we have to do that for clinical as well?
Yeah, do you have the screening form?
I think she sent out an email last week about it.
Yeah, I'll bring some extra copies of it also. But yeah, I will be collecting that from each of you at clinical, the screening form.
The screening form is separate from the link that she sent out. The screening form is in the email that Edward sent
Right.
to all of us. The other one is the link for when we go onto campus.
Right. Yeah, so don't fill out the link that when you're going to campus. Don't fill that out, because then they'll expect you to be showing up at the front desk and get your temperature taken at campus. And Mrs. Sipos actually gets like an alert if you haven't had your temperature taken, and she'll go looking for you on campus. So when you come to clinical, just fill out the clinical pre-screening form. So the way that we're breaking down the grading this semester, exams are going to be 40%. I'm basically planning for 4 exams, but we don't break it down specifically so that if we have an exam that's really bad or something like that, you know, I could add more exams. I have that flexibility, but exams will make up 40% of your grade. Quizzes are going to make up 9% of your grade. I'm going to plan for 3 quizzes. Basically 3 will be before, like the week before the exam, and will help you prepare for that exam. Outside assignments will be 6%. Those are going to be, 6 graded, either individual or team assignments. Your lab with Mr. Eckhart, is that how you say it, Eckhart? Is 10%. Gerhardt, thank you. I believe he's planning on like 4 sims and either 2% for the final or maybe a quiz or something like that. And then your clinical is 10%. PPS is 5%. And remember that if you receive a deduction in one area, that gets deducted the PPS from all your classes. So, each time you're losing points, it's affecting all of your grades. Kaplan, we're going to have 2. It's not, it may be Kaplan or it may be another, like, I can build comprehensive exams in PrepU also. So it depends on, accessibility, what tests we have in Kaplan, and how, if we still have accessibility to campus or if that changes. But I'm going to plan for the 2 Kaplans. There's an OB one and there's a PEDS one. So that will come. I'm going to do the OB one like halfway through the semester, so we're not doing the 2 Kaplans at the end. The final exam will be worth 15%. Okay, any questions about the grading? And of course, as you read through this after, if you ever have any questions about any part of the syllabus, feel free to email me, okay? So when we look at some of the main concepts and areas that we're going to be covering, I think it's really helpful if we kind of chunk the information, right? So this first part of the semester, the first few weeks, we're going to be looking at normal reproduction and then alterations in reproduction. And then the first exam is week 3. Then we're going to move on to care of the newborn, care of pediatrics, and then there'll be a second exam. And then we're going to look at alterations in sexuality and sexually transmitted diseases. And then at the end of reproductive phase, like menopause and organ prolapse from having hysterectomies and benign prostatic hypertrophy. And you're going to have a continuous bladder irrigation sim that's going to go along with the BPH exemplar. And so that's kind of the alterations in sexuality. And then from there, we're going to go more into like, your psychiatric illnesses and spectrum disorders, and then mobility with the difference between the osteoarthritis and the rheumatoid arthritis and other fractures and other mobility alterations. And then the alterations in neurosensation, such as multiple sclerosis, Lou Gehrig's disease, ALS, Huntington's disease, and Parkinson's. And then we do cover like alterations in vision and hearing and neuropathies. So those are some of our main exemplars and concepts this semester. So, but don't worry, we have 16 weeks to cover it all, right? Or 15. We can start counting now. Do you feel us kind of on the surfboard together, kind of, rowing out and catching a wave here? So we're going to really approach this, though, the semester in terms of family-centered care, right? See how in pediatrics, we really have that focus on including the whole family. The parents have to learn the care. You have to, direct teaching and learning needs with the parents. But really, what works in peds works in the adult world, because in the adult, and we saw this during the coronavirus, right? When the elderly people couldn't have their family members visit, it affected the level of care that they received. And then we want to look at, that human development, those theories, developmental theories. Erickson's kind of the really big go-to, right? That trust versus mistrust, autonomy versus doubt, industry versus inferiority. And then that holism of that person, right? The different aspects of the human person, our professionalism, critical thinking, and caring, and health promotion and maintenance is always, even though we're moving on from that, we never really truly move on. We're always, every time we interact with that person, we're looking at educational needs. How can we help them make those, choices to decrease their risk, to help maintain optimum health and manage their disease at home? What are things with these exemplars that we need to teach for that person to be able to go home and take care of themselves? So, some of these concepts, looking at addiction, right? Because, if somebody is addicted to nicotine, prenatal care, right? Get them to stop smoking. What would that potentially, how does that affect the newborn baby if they're exposed to substances in utero? Anxiety, cognition, communication, elimination, homeostasis, hydration, immunity, infection, metabolism. We're gonna have a little immunization debate. That's a fun. There's a few weeks in here that I have activities built in that I really look forward to. I look forward to that immunization debate. I look forward to, we have a game day. Yay, it's game day. And, you know, I really want to bring that on campus. So we will have a class where I might have, I'm kind of envisioning this being out on the patio when it cools off a little bit at school, and having some areas where you could rotate through and do some team games to facilitate your learning. So like I said, I really feel like this is a very fun semester, but it's a lot of work too. So mobility, I talked about metabolism, neurosensation, we do jazz hands for that, neurosensation, nursing process, nutrition, oxygen, pharmacology, regulation, reproduction. Reproduction's a big one, of course, starting out. Safety and quality, technical skills, and tissue perfusion, okay? Providing care. So you need to know your audience to provide care to those in the acute care setting. The hospital setting presents with all ages and genders and culture and ethnicities and belief systems, right? When we think about, you know, you walk into one room and you have this, you know, a woman from, you know, with a sari, and they're giggling over breastfeeding, and then you walk into another, out of that room and into another room where there's two, you know, parents who are lawyers, and they're questioning every detail about the medication that you're giving and wanting to know every side effect and potential adverse reaction. And, you know, and then you walk out of that and then you walk into another room where, you know, they are homeless and they have limited resources and they're a very vulnerable population. You know, you just interact with so many different people in the hospital setting. It's just, it really is fascinating. So, you know, as the RN, needing to know what is that normal physiological process, right? What's that structure and function of that system? And then how do I identify the abnormals, and, you know, what, in identifying those abnormal assessment findings. In that intermediate novice area, you know, level, you're not always going to know how to describe that finding. And that's where you get the nurse, your instructor, to kind of say, okay, this is what I'm listening, you know, what I'm hearing. How would you describe that in your assessment? And use your resources. So providing culturally competent and respectful care always. And looking at those different ages and the growth and development by age, right? And how each area, each age group has milestones that they meet, right? And whether it's, you know, intimacy versus isolation, and identifying their sexuality and finding a partner or somebody to, you know, have a relationship with. They also have their hardships then, right? Not finding that person, not wanting to accept their sexuality. Looking at, you know, infants poisoning, near drownings, being left in a hot car. You know, how do toddlers die? At adolescents in substance abuse or depression and suicide being a huge problem, right? So you as the acute care nurse, right? Realizing people are living longer also, right? In our book, this week's reading, it talks about how women in their 50s experiencing menopause now go on to live like 1/3 of their life is postmenopausal. And those increase in those comorbidities, you know, with osteoporosis and things that maybe, you know, decades ago, women weren't living that long to have those increased comorbidities that you're going to be taking care of, that you know, growing age group. So, you know, you have job security, right? So there's that huge nursing shortage on the horizon, even more so now, you know, post-pandemic, or we're not even post-pandemic yet, right? In seeing just that need for you to be out there, providing care to patients. So thinking of how that role, you know, you're not just delivering medications, giving baths, right? Now that focus on that critical thinking, you being the communicator, coordinating the plan of care, identifying changes in your patient status and notifying that physician with your recommendations. Nurses are so much more of that critical thinker, the eyes at the bedside. Excuse me. So thinking about those attributes, the part of that professional nurse, right? Just to review, being autonomous, compassionate, critical thinker, right? Having that knowledge. Romance. Do you have a question?
What is our book?
At the very beginning of the syllabus, it has your resources on there. We're mostly using the maternity and pediatric nursing book. It's really beautiful too, actually. Let me get it. Okay. This maternity and pediatric nursing book. This beautiful, like, mother caring for her infant on the front. So this is one of our textbooks. We're also going to be using the Med-Surg book still. And, you know, your fundamentals is still a resource. I like that medical terminology book also, because the reproductive systems, and if I have time today, there's resources in there for games, interactive games. Have you ever done the robo terms? It's kind of like Hangman, only robot arms fall off and stuff. Those games are a lot of fun, and they'll help reinforce your learning. And also, there is the psychiatric nursing book. We'll get into that in the end when we get into those psychiatric disorders, the mental health disorders. Okay? I have posted a quick view outline, and all of your reading assignments are in there. Okay, so this week we're starting out with chapter 3, which is your reproductive organs, and then moving on chapters 11 through 16. But you know, you'll peruse through, so it's preconceptual care all the way through postpartum care. Okay. Excuse me.
Thank you.
Thank you. Good question. Anybody have questions about that critical thinking, right? Identifying trends and changes in your patient, putting together that data, being able to make a decision, critical decision, that decision making, thinking critically, prioritizing, right? It's applying nursing process, looking at the assessment findings, and being able to solve the problem. What's going on with my patient? Identifying the problem and fixing it, right? We talked about kind of that process with acid-base imbalance. So it's really that essential component of giving care, right? That cognitive skill of analyzing and applying standards, looking at evidence-based practice. You know, what do we know? What is our knowledge base in terms of science in taking care of patients holistically? And this patient and family-centered care, right? So us as the critical thinking nurse, we don't just practice nursing in a bubble. We're interacting with interprofessional, interdisciplinary team members, with the patient being at the center. In pediatrics, like I like to say, right? What's good in peds is good for everybody. I think there's so much truth in that. I think so many times I saw where we would implement a new program in pediatrics and it caught on like wildfire and went on to the adult world. One of the things that we did was family-centered care rounds. And you will see this. When you get to peds, I want you to make sure that you go into family-centered care rounds when the doctors come in and do rounds. And all the members of the team, the charge nurse, the nurse taking care of the patient, pharmacy, and whoever else is involved. If it's dietary, you know, if it's PT, they're in there, and the resident, and they'll go in and they'll say to the parent, hi, are you the parent? And they'll introduce themselves. They'll introduce themselves to the members of the team, and then they'll say to the parent, how do you feel like your child is doing? What's going on? And they listen, and then they discuss the plan of care. And if there's any gaps in the understanding of the status of the patient and the plan of care, then they'll work to discuss that and all get on the same page with, what are the goals for that child to be ready to go home. So recognizing, and your book emphasizes this too, and how the family is the constant, right, for that patient. They might be coming out of that home environment into the hospital environment, but if we don't address the situation, that the family that they're going home to, and making sure that everybody understands the care and what they need to do at home, then that's not taking care of the patient. So we need to empower families to make their decisions. We need to respect their culture, right, and their religion and their practices and beliefs. And, and then especially the changes that we've made in the birthing process, right? The importance of having that father be part of that whole experience and not excluding, the family members from the birthing experience. We think about how that helps decrease the pain experienced by the mother when the mother feels that support from the family and from from friends and family around her. So think about how you would describe family-centered care in terms of allowing visitation in the hospital, in terms of education, in terms of beliefs, right? So Garrett, how would you describe family-centered care? How's that different from patient?
I'd say that family-centered care is when you're, including everybody in the family and making sure like all their voices are being heard. Mm-hmm.
So how might that situation be applied to end of life, to code situations?
Well, with end of life care, you may have to, like, if they had a DNR, the family may not be aware of it. You might be trying to explain to them why you're not trying to save their life at that moment. And it may have to be explaining like this was the patient's wish, and it may be a difficult conversation to have, but you still have to include them, and you can't just not tell them why you're not doing what they would be expecting you to do.
Very good. Yes. Yeah. And it might mean hopefully you would have an opportunity before the patient codes to get social work or case management or the physician involved, and maybe even have a little conversation with the family members, with the patient, facilitating their wishes and how they want, because at any time, if that patient becomes incapacitated, the family can change, the decision and want those measures to be changed, right? Unless they have, orders in place to maintain the patient's wishes. And also, we're seeing a change in healthcare that we're allowing families to be present, parents to be present during a code with the child. That, in the past, it used to be, have the parents removed if the child coded, where now we've found that it's better to have that kind of transparency and, have somebody with the parents that can explain what's happening, what's going on, but actually encouraging that parent to continue to talk to the patient during the code. We're right here, mommy's here, and how that can kind of help the family feel and trust that everything's being done and understanding the care that's being given to the child. So have you seen that, Haley, in the clinical setting?
Yeah, and right now it's kind of nice because there's some lenience with the pediatric world compared to the adult world.
In terms of allowing visitation, right? Because they need to be there.
What they also allow some specialty, if a child's a little bit delayed and they're over the age of 18, they're still letting them come in with parents.
Yeah, very good. So, we can think about how you would provide family-centered care in different areas, in OB with allowing, family members and partners to be there during delivery, in peds, in med-surg units, in the ICU units. So we're always talking about minimizing separation of the children from the parents. It's really, and I would like to, in future weeks, one of these weeks, have a child life specialist come in as a guest speaker and share their role and how they provide atraumatic care. One of the most important things is not to do painful procedures in the patient's room. We, as much as possible, remove them. Their room needs to be their safe place, and the place where they can rest and sleep and not worry about somebody coming in and poking them or, doing something painful or stressful. We take them into a procedure room, and then after they have their procedure, we let them pick out a toy from the toy closet, You know, PMI nursing students have donated toys to the toy closet in the past. They also, when they go home, they get to pick out a book to take home with them, a new book. And we've donated to the book closet also. We use Child Life to help normalize the hospital experience and do play therapy and education and include parents and explain, you know, what they're going to feel and what they're going to see. And of course, always explaining why we're doing something, you know, and helping the, you know, the parent really is key in helping, you know, that family-centered care, you know, making sure that we're using words that the patient is familiar with. You know, what words do they use to go to, you know, to let us know they need to go to the bathroom or that they're in pain. Kids with developmental delays like cerebral palsy, right? Brain damage. How do they express their pain or express when they're hungry? You know, parents know their verbalizations and their body language and things, and can, you know, help us learn that, you know, specifics about that child. So, and how do you assess the family unit? You know, how do you look at how the parent interacts? How stressed is that parent? You know, is there a concern for child abuse too, right? So how can we be a support to that family and providing safe patient care to the child? So, you know, interviewing the individuals in the family, how they interact, you know, if there's divorce and things, if there's tension between family members, sometimes that means, you know, taking them out in the hall and saying, you know, okay, this is good that you all want to be here for your child. That's a good thing. But how can we not have stress in the room? Or, you know, you know, I like to call them little come to Jesus meetings, you know, letting them know, you know, we can't have, you know, violence basically in the room, right? So, you know, individual client-centered care, family unit, family-centered care, right? Each family member affects each other and affects the health of the family, right? We'd say, you know, there's sayings like people eat at the same trough, right? So if, you know, obesity is an issue in the family, you're not just going to address it with the individual child, right? It needs to be the whole family that's looking at how they can eat healthier, or how they can, you know, make other changes in terms of health promotion. Smoking, right? How many times do kids, and it's interesting too with like diabetes, how many times a child has turned to the parent and said, now you're going to have to eat healthier, aren't you? Right? It's cute when you have the child kind of, it's like, sometimes I think that could be a good thing for the whole family when a whole family has to change a health practice. So, and looking at culture, of course, who's making decisions in the family. Language barriers are huge. You know, I think it's very difficult, even though you might have some understanding of Spanish, one word can change the whole meaning. And that can be dangerous in a health, you know, when you're dealing with, you know, medications and things. You want to make sure that education is accurate. Using the Seracom phones. Every bedside has a Seracom phone at TMC, and it's really easy to use. You're following prompts and pushing buttons, and you get an interpreter with an identification number that you document, and then you know, explain what you're saying. They interpret it. You got 2 headsets, and you're going back and forth. You maintain eye contact with the parent or the family member so that you're communicating. And you know, if it's somebody who needs sign language, they have the screens that we also use for telemedicine. So, you know, getting those, we also have interpreters that you want to make sure you're using an approved interpreter and not a family member to interpret. Yes? Is there a question? I thought I heard something. Okay. So, you know, explaining treatments, making sure that we're looking at male and female, you know, caregivers, and what are the preferences of the family. And then what is their perception of medical care too? Is their use of complementary and alternative medicine, those kind of things that we've learned about already. in terms of providing culturally competent care, in your book, there's this link, and you can go back and actually take a questionnaire and look at your own biases and your perceptions of culture. Okay, so we want to make sure that we're not assuming things, that we're treating everybody as the individual that they are, right? That individual assessment of their culture and their cultural needs. And, you know, remembering about, so part of that, there's a section on your assessment for your clinical paperwork that talks about religion, ethnicity, race, and practice of complementary or alternative medicine. So make sure that you're including all of this information there and, you know, assessing for that on your patient. In this, so Romance, talking about this book, this maternity and pediatric nursing book, at the beginning of every chapter, there are the most, just funny little, these wow words. They're supposed to be so profound, right? But I always get a little laugh out of them. So the first one about this normal human reproduction is that all nurses should take care of and respect the human body, for it is a wondrous, precise machine, right? Like, don't let that blow your mind, okay? It's words of wisdom. So when you're doing your reading, always make sure that you're getting that moment to lightheartedly kind of laugh at these, or maybe there will be some of them that will strike you as, oh, that's very profound. But just so you know, as nurses, you should take care of and respect the human body, for it is a wondrous, precise machine. And it is, you know, it is, isn't it amazing? As we learn about the different systems and how they affect each other. So it is argued, okay, so we've learned about some important systems, right? Cardiorespiratory system, you know, strokes, neurological system, kidneys, you know, and the importance of, you know, excretory functions and things of the body, acid-base balance, and all these different, you know, systems in the body. But it can be argued that the reproductive system is the most important system of the body, right? Because without the reproductive system, the species would die. So there's a little profound statement there, right? Without the ability to reproduce, the species dies. So we're learning about, it could be argued that right now we're learning about the most important system in the body. So we're going to start out by just looking at the male and female anatomy and the external and internal organs. And you might think this is all very straightforward, right, and simple, but I'll tell you what, some students got some of these questions wrong on the test. So even though you might think you know your parts, review your parts, right? What's internal, because the vagina is not an external organ, guys, right? I thought that was kind of funny. Anyway, so, and then we're gonna look at, you know, pregnancy, kind of your planned and your unplanned pregnancies and uncomplicated pregnancy, and those different stages of pregnancy. One thing that I thought was interesting is back when I had my children, I didn't know about preconceptual care, right? Are you all familiar with preconceptual, like before you're even, so when you're first planning to get pregnant, that's when you really should interact with your OBGYN. Okay, because that's when they want to assess what are the risk factors, what's the diet, what's the risk for diabetes, what are the medications that the woman's taking, how much weight should she be gaining during pregnancy, what's the risk for diabetes, what's the blood pressure, you know, all those, you know, looking at starting to take the prenatal vitamins. Who knows, what is that, what is the big mineral or, you know, vitamin that women need to take to prevent neural tube defects? This is like NCLEX worthy information. What's the
folic acid?
Folic acid, very good. And how many micrograms? Do you know that? And then if there's a history of neural tube defects, they increase it by like 100-fold. So we'll be looking at that. I think it's 400 mics, and then it goes up to, yeah, anyway, it's in here somewhere. We'll look at that. So here's the joke, okay? Just be glad that you don't have, like, you're online, right, with this class, because in the past, I felt like anytime we were out in public and you'd be like opening up your book online, this picture would come up, right? Or if I got my hardcover textbook, I'd be in the doctor's office and boom, it opens up to this page every time. It's like, why did that page every time, you know? And I think it's funny with textbooks. It's always the most, you know, like, you know, so the external organs of the female system, right? So you have the mons pubis, the symphysis pubis, and you have your different skin folds, the prepuce, which means covering, right? Your urethral orifice, and the labia majora and minora, and the clitoris. So you got all your external organs of the female, okay? I'm gonna kind of take a funny little break time. We'll take a break in 5 minutes. So the mons pubis is the elevated fatty tissue over the symphysis pubis. It's covered with pubic hair, and it's intended to protect the symphysis pubis during intercourse. So the labia majora are the two large skin fold lips that protect the vaginal opening and protect during sexual activity and contain sweat and sebaceous glands. The labia minora are the smaller skin folds underneath that are more delicate within the labia majora, and they surround the vaginal opening and urethra. They provide lubrication to the vulva. They swell in response to stimulation, and they're highly sensitive, along with the clitoris, which is a small cylindrical mass, cylindrical like a cylinder, little cylinder-shaped mass of erectile tissue and nerves. It's almost like a smaller penis on the female. Purely erogenous function that has folds that create a hood-like cover over the prepuce. The hymen, so now that's still external, but right in here, is a tough elastic perforated mucus covered tissue that encircles the vaginal opening like a tight ring. And the vagina is a tubular canal lined with a mucous membrane that lies in front of the rectum but behind the bladder. It connects the cervix to the vulva, and it's the passageway that receives the penis and sperm, and it's the exit for menstrual blood and the fetus during childbirth. The uterus is an inverted pear-shaped organ that acts as the site for menstruation and fetal development. The cervix is the neck of the uterus that's lined with mucus-secreting glands. Okay, the cervix. And the corpus, the main body of the uterus, with mucus, where the implantation of the fetus takes place. The fallopian tubes are also called oviducts. Okay, oviducts or fallopian tubes. They are hollow cylinder-like structures lined with cilia that facilitate a path for an egg from the ovary to the uterus. So that's where you can get strictures and scarring along fallopian tubes that will lead to problems with pregnancy. And the ovaries are the two almond-shaped pair of glands responsible for gamete production, develop and release the ovum, the eggs, and secretes estrogen and progesterone. Okay, so at this point, let's go ahead and we'll take our next 10-minute break, and we'll move on to the male reproductive system, and I'm going to kick off the semester with a little surprise bang. Okay, so you can look forward to that when we come back from break. 10-minute break. The break is a good thing.
Miss Erickson.
Yes. Hi, Ashley.
So I was gonna send you an email after class, but I just wanted to like say it before I sent it. My Zoom is like being real grumpy this morning, so it's lagging like crazy. So I just took a little quick video of it and I posted it to YouTube to show you. So that way, if you call on me and like I don't understand the question or something, I just wanted you to know my struggles.
Yeah,
so.
you're lagging on your video too as I'm watching you. So yeah, it must be, I wonder if it's a bandwidth issue or.
I don't know. And I even had my camera off during when you were sharing your screen earlier, and I can't like understand more than like 2 words.
Okay.
So
well,
just want to let you know.
Yeah, I'll make sure I post lecture after. You know,
Okay,
even though,
thank you.
yeah, even though there's break times on it and stuff, you can always just go forward on the video, you know,
right,
on the YouTube video. So go to the
Thank
sections that you missed, you know. Okay, I want to make sure everybody comes back because you're not going to want to miss this. I have to have my fun occasionally, you know. Go on speaker view here. Okay, is everybody back? Let's see. Okay, so one of the important aspects of learning about, you know, the reproductive system and sexuality is, you know, we have to have a good understanding of, you know, the structure and the function of the reproductive system so that we can feel comfortable discussing it with our patients and helping identify alterations and issues, you know, providing education. So, you know, being comfortable and knowledgeable is really important. So I hope that nobody gets offended. I know people can, you know, be uncomfortable with certain things, but understand that the rationale for why I'm doing this is to just recognize that we need to know that all parts of the body are normal, right? That we shouldn't feel, you know, uncomfortable, even though I feel uncomfortable. You know, you have to be careful with what you say, right? I don't want to be offensive in any way. But that being said, I had a previous assignment with students, and I had a student who did a model of a reproductive organ and the function of that reproductive organ, and she gave it to me. So I have incorporated this into the beginning of every semester to just kind of reinforce the importance of being comfortable with what we're discussing as much as we can be, you know, but just remember that I don't mean any of this to be offensive in any way, okay? So, so here is my prized possession, and it works, okay? So this is the ejection, you know, so this is kind of fun in the classroom because, you know, you could have actually seen how it works. And so you see that we can go ahead, you know, the whole process of the penis becoming, you know, engorged with blood and then being able to, you know, in male and females, we have the same kind of sexual response. It talks in the book about how you have that excitement and that building that climax up to orgasm and then that resolution phase, right? So male and females pretty much have the same sexual response, as much as we might think it might be different from one sex to the other. And then you see that we can actually make this penis ejaculate. There he goes, right? So we're starting off the semester with a bang. Zoom, hey, there he goes. Now my seat's wet over there, but anyway, right? Ta-da! Like size doesn't matter, right? You know. Anyway, I'll put, like I said, I won't be offensive, okay? But just to lighten the mood a little bit. We're starting the semester off right. I thought she did a wonderful job on that project. Definite A. Okay, so where were we? Back to business, right? Okay, so there we have the external organs of the male reproductive system. It's basically the penis and the scrotum, right? The thin sac that protects and regulates the temperature of the testes. So we know that it's really important for that area of the body. The reason why that's external is that the sperm have to be kept cooler, right? That can be a problem when the sperm are too hot. Like we teach, young men about dangers of hot tubs and those kind of things that can affect sperm production. So we have the penis, which is the outlet for the sperm and the urine. It becomes engorged with blood during sexual arousal. The glans is covered by the circular fold of skin, unless it's removed with circumcision, right? So you have the prepuce, which means covering, and that's what the glans is called, the foreskin. So the actual penis consists of three cylindrical, like a cylinder, right? I'm having problems saying cylindrical spaces. There's sinuses, three different separate sinuses of the erectile tissue. Two larger ones, the corpus cavernosa, are side by side, and then the third sinus, the corpus spongiosum, surrounds the urethra. The scrotum is the thin sac that protects and regulates the temperature of the testes. And then the testes produce the sperm and synthesizes the testosterone. They're two oval-like structures, kind of that nut-shaped, that sit in the scrotum. They contain the epididymis, a coiled tube that collects the sperm and allows the sperm to mature. Then there's the ductal system. So there's the penis and the scrotum, and then the ductal system, and then there's the accessory glands. So those are the different parts of the reproductive system of the male. So the ductal system contains the vas deferens, which transports sperm from the epididymis to the back of the prostate and enters the urethra to form the ejaculatory ducts. The urethra that serves as the passageway for semen and urine. You have your accessory glands, okay? So know the difference between the ductal system and the vas deferens, and then the accessory glands, which are the seminal vesicles, the prostate gland, and the bulbourethral glands, or the Cooper glands, okay? So the seminal vesicles produces nutrient seminal fluid. So there's actual fructose and prostaglandins for sperm energy and mobility. And then the prostate gland produces alkaline prostatic fluid because the vaginal area is a very acidic environment. So for the sperm to actually survive and be able to swim through the cervix and impregnate the woman, you have to have protection for the sperm to get through that very acidic environment. So the prostate gland produces an alkaline prostatic fluid that accounts for most of the semen volume. And then the Cowper's gland, or the bulbourethral gland, are two pea-sized structures with epididymal lining that secretes a mucus-like during sexual stimulation to lubricate the head of the penis for intercourse. And those are the external and internal organs of the male reproductive system. So now there's 4 different times of pregnancy that we really look at assessing. Preconception care, prenatal care, the antepartum care during labor and delivery, and then postpartum care. So now we're going to kind of switch gears, and we're going to move and kind of cover the information from chapters 12 through 16. And that's a whole unit. Actually, it's two of the units in your maternal and pediatric book here. So I'm going to post, there's reproductive videos, and they're really cute. In next class, we might have some time to spend on them, but I do want to also lecture on the exemplars next week. But what's cute about them is each of them has, like, the woman has a different name for that stage of pregnancy that she's in. But I'm kind of looking at time, and we might not have time to get to all of them today. So yeah, so this is starting in chapter 12 with preconception care. So how do we know if we're a little pregnant, right? That's kind of the thing. So some signs of pregnancy don't really confirm pregnancy. It's really important that women, when they're getting pregnant, that they know that they want to go in and they want to actually get that positive pregnancy test. And they want to, but that just a positive pregnancy test alone isn't like 100% that they're pregnant. There's other things that can actually cause a positive pregnancy test. Actually hearing a fetal heart rate is the most positive sign of pregnancy. Seeing a baby on ultrasound is a very good positive sign of pregnancy, right? So there's other more presumptive signs, right? Some of those presumptive times, the woman not having her period, absence of menstruation, having nausea between weeks 4 and 14. So with the increased hormone levels come, that morning sickness, okay? Fatigue, women will often feel more tired when they become pregnant. Breast tenderness, urinary frequency, which is a result of hormonal changes also. Mood swings, cravings, abdominal bloating, those are all subjective or presumptive signs of pregnancy. Probable signs, how you know you're probably pregnant, okay? If you have softening of the lower uterine segment of the cervix, that's Hegar sign, H-E-G-A-R, apostrophe S. Hegar's sign means that the lower uterine segment is softening, the opening of the cervix. And then the softening, so that's the isthmus part of so softening of the whole cervix is Goodell's sign. Or Chadwick's sign is this bluish purple coloration of the vaginal mucosa and cervix. That's also, you're probably pregnant. Abdominal enlargement, but you can't always just assume they're pregnant, right? So don't ask them if they're pregnant just with abdominal enlargement. I've just gained weight, no. Braxton Hicks contractions, false contractions. Ballottement, it's when somebody does a exam and they push against a woman's cervix and they feel rebounding of the cervix because of the fetus, the floating fetus inside causes a rebound of the cervix movement. That's called ballottement. Breasts become larger, there's weight gain, edema, positive pregnancy test, and stretch marks. Those are all probably pregnant if you're experiencing all those things. Positive signs, okay? This means you are 100% pregnant, right? An experienced healthcare provider can confirm the patient's suspicions by identifying positive signs of pregnancy that can be directly attributed to the fetus. Positive signs of pregnancy confirms that a fetus is growing in the uterus. Visualizing the fetus by ultrasound, palpating for fetal movements, and hearing a fetal heartbeat are all signs that make a pregnancy a certainty. Once pregnancy has been confirmed, the healthcare provider will set up a schedule of prenatal visits to assess the woman and her fetus throughout the entire pregnancy. And assessment and education begins at the first visits and continues through the pregnancy. Okay, so some of the important parts of that first visit is getting blood glucose checks and identifying for risks for diabetes. Okay, so some of the physiological adaptations, what happens? So adaptations of the uterus, right? The size of the uterus increases 20 times that of the non-pregnant size. So that uterus grows 20 times bigger. The capacity increases by 2,000 times to accommodate the developing fetus. Weight increases from 2 ounces to approximately 2 pounds at term of the uterus. The uterus is going to gain that from 2 ounces to 2 pounds. Uterine growth occurs as a result of both hyperplasia and hypertrophy of the myometrial cells, and increases in strength and elasticity to contract and expel the fetus during birth. So that uterus is an amazing reproductive organ. The cervix increases in mass to be able to hold the pressure, the weight, hopefully, unless it's an incompetent cervix, right? But hopefully that cervix is good and strong. It increases in mass and water content and vascularization. And it changes from regularly rigid to soft, distendable structure that's going to stretch and allow that fetus to be expelled. And under the influence of progesterone, a thick mucus plug is formed, which blocks the cervical O's and protects the developing fetus from bacterial invasion. So the cervical plug forms, and that's important then when the mother starts going into labor and that cervical plug
falls, is removed, then that in the water, the membranes break, allows for bacteria to travel up, and that's when the baby then can get a bacterial infection. So these are ways that the cervical plug protects the baby from infection. So the vagina itself increases in vascularity. So you have increased blood perfusion to that area because of estrogen influences, and results in pelvic congestion and hypertrophy. So everything becomes more swollen in the perineum area. Increases in thickness of mucosa, along with increased vaginal secretions to prevent bacterial infections also. Ovaries, they increase in blood supply to the ovaries, cause them to enlarge until approximately the 12th to 14th week of gestation. They actively produce hormones to support the pregnancy until week 6 to 7, when the placenta takes over the production of progesterone. The breasts also change. That begins soon after conception. They increase in size and the areolar pigmentation. There's a picture in your book of that. The tubercles of Montgomery enlarge and become more prominent, and the nipples become more erect, and the blood vessels become more prominent, and blood flow to the breast double. So generally, the whole cardiovascular system has increased blood supply. Respiratory system is affected because of the weight and pressure on that. Musculoskeletal system, the hips widen, right? And the spine changes, the woman gets more lordotic. Integumentary, they can have rashes and different skin issues related, in stretch marks also, but more the skin rash. In the Niagara linear, there's a dark line that runs from the umbilical area to the pubis that forms in pregnancy. And there's changes in the endocrine system and the immune system, and GI and GU, of course, with urinary frequency. And and also partners go through changes also. Okay, so expectant partners can go through anxiety. They have changes in their role as how they perceive their role as breadwinner and caretaker and support person. The reality then, they have a different reality too. They sometimes aren't as accepting of the pregnancy until they can see that fetal movement. And there can be a lot of confusion from the partner with the woman's mood swings. And if the woman might have periods of introspection where they're kind of dealing with emotions. And especially during the 3rd trimester, the expectant partner starts to really prepare for the reality of this new role and negotiates kind of what the new role will be, and their role during labor and delivery process needs to be decided also. They might really express, the partner might express concern about being the primary support person, and they might worry about how they're going to react when faced with their loved one's pain. Expectant partners share many of the same anxieties as pregnant partners, and it's more uncommon for the partner to reveal their anxieties to the healthcare provider. Often how the expectant partner responds during the 3rd trimester depends on the state of the marriage or the partnership, and whether it's struggling or their impending increase in responsibility may cause them to kind of feel further away from their partner. They might work late, they might stay out late with friends, or they may begin new or superficial relationships. In the stable marriage or partnership, the expectant partner may be struggling to find his or her place in the pregnancy, and they might find concrete tasks to do. They might paint the nursery, assemble the crib or the car seat, or attend the Lamaze class, and those kind of things that the support partner can do. Okay, so weight gain and nutrition is key in pregnancy. So following my plate, right? A variety of foods from each food group, they need increased protein. There's evidence-based practice, little box in your reading about how increased protein increases positive birth outcomes of the fetus and prevents fetal death. So if the woman is underweight, The total weight gain should be 28 to 40 pounds. Normal BMI, 18 and a half to 24 for the BMI. Weight gain should be 25 to 35 pounds. Overweight women who have a BMI of 25 to 29 should have less weight gain, 15 to 25 pounds. And if the woman is obese, if the BMI is 30 or higher, they should only gain 11 to 20 pounds so that they have a decreased, comorbidities. Women need to be taught to take their prenatal vitamin and mineral supplement daily. They should avoid any weight reduction diets during pregnancy, though. They need their nutrition. The baby needs their nutrition. They shouldn't skip meals. They should eat 3 meals with 1 or 2 snacks daily. Limit intake of soda and caffeine. No coffee, very little. And they should also avoid any use of diuretics during pregnancy. They do not reduce the use of salt unless they're instructed to do so by the healthcare provider. And they should have reasonable exercise. Usually it's whatever they were doing pre-pregnancy is safe to do during pregnancy, as long as it's monitored by their physician. But no vigorous activity that could cause them to fall or be injured, unless, under the direction of their physician. At the first prenatal visit, so we're talking about preconception care, things that we're going to assess for when they're going to be getting pregnant. We want to look at the woman's immunization status, their medical condition, medications that they're on, seizure meds or other medications, especially acne medications can be tetragenic. So there's certain medications that are associated with birth defects, right? So anything like that, we want to make sure that they stop taking it and that medication is out of their system before they're going to consider getting pregnant. Their reproductive health data, their status, if they've had spontaneous abortions previously, what are their sex practices, their nutritional history, where they're at on their BMI, lifestyle and occupation, and psychosocial, family support. So we want to review all these things with them to prevent any adverse pregnancy outcomes. Then at the first prenatal visit, we're going to screen for diabetes. Remember that fasting, the goal is to have the fasting blood sugar be less than 126, right? And so at the first prenatal visit, we measure fasting plasma glucose, a hemoglobin A1C, or random plasma glucose on all women or high-risk women based on risk factors, weight status, and family history. And it's box 12.3 in your book, so review that. If the glucose testing is not diagnostic of diabetes, of overt diabetes, then the woman should be tested for gestational diabetes from 24 to 28 weeks as a follow-up. With a 2-hour, they take 75 grams of oral glucose. It's really sweet, nasty kind of tasting stuff. And they do a glucose tolerance test, a GTT. So at that first visit, they're going to get that comprehensive medical history, the head-to-toe exam, and lab tests. So then at regular follow-up visits, the woman can expect to have fundal height measurements. What's really cool? So they measure from the umbilicus to the symphysis pubis. And with the increase, every centimeter of increase is a week of gestation as it gets bigger. So, and then they'll do the fetal heart rate measurements. They'll teach about danger signs like seeing spots or increase in the blood pressure or swelling of the ankles, management of discomforts like hemorrhoids and shortness of breath and urinary frequency, and of course, morning sickness, and preparation for childbirth, and coordinating what expectations the woman has for pain management and for where she wants to have the childbirth. There's use of midwives and doulas, and some people want to be in a birth center versus in a hospital. So it all depends on the needs of the anticipated needs of the woman with delivery and level of care or pregnancy complications. So some of the signs that the woman, now moving kind of into that antepartum care, signs of labor, cervical changes, this feeling of lightening with the baby moving. All of a sudden the woman will have this increased energy level, and maybe do some nesting activity, getting the nursery ready, doing some housework and cleaning, and then losing some of that mucus plug, this bloody show. Having increased in Braxton Hicks, these false labor contractions, having the ruptured membranes. So there's 10 P's, there's 5 main P's in the book, and then there's kind of some associated P's with that are listed in your textbook. And it has to do with the passageway of the woman, you know, what is the inner spines of the hip bones so as the baby can move down that passageway. Is there a problem with the actual passageway? Is there a problem with the passenger? Like, what is the size of that baby? And can the baby move down and engage in the birth canal and move through the birth canal, or is the baby too large? And then there's the powers, so the actual force of the contractions and everything. Let me look up the others. So powers. I wonder if I have them on here. Aren't those wonderful pictures? Position. Powers, position. Okay, so passageway, passenger, powers, maternal position, and the psychological response. So those are the 5 factors that affect the labor process. And then under the psychological response, they looked at the philosophy of the woman and how they view childbirth, their partners and patients, because the birth process takes time, and patient preparation and the prenatal education and pain management. So those are the 10. And they're very clear in your reading, and they explain each one of the different aspects of the P's. Okay, so then you have your stages of labor. So the first stage of labor is just this early labor. It goes into an active phase where the contractions get more frequent and higher intensity. And then there's the second phase, third phase, and the fourth phase. So first stage, in the latent and early phase, the contractions are usually every 5 to 10 minutes. And they last 30 to 45 seconds. The active phase, the cervical dilation begins to occur more rapidly. They're 40 to 80% effaced. So effacement is the actual thinning of the cervical membrane as the uterus opens, and then the dilation is the centimeters that the uterus opens, and it opens up to 10, and then the woman pushes and delivers the baby. 10 centimeters is fully dilated. So at that point, when the dilation is from 8 to 10 centimeters and the effacement, the thinning of the cervix is 80 to 100%, then they enter into the transition phase and they get ready for the second phase of delivery, which then is when they start to push. So the second stage of labor begins with complete cervical dilation, 10 centimeters, and effacement, and ends with birth of the newborn. Okay, so the pushing, and then in the third stage is the placental separation and the placenta expulsion. So what happens when the signs of the placenta separating is the uterus rises upward and the umbilical cord lengthens. There's a sudden trickle of blood as the placenta is released from the vaginal opening, and the uterus changes its shape to more globular. It's really important that the nurse and the physician assess the intactness of the placenta and make sure that there's no retained fragments. Sometimes the physician will maintain a gentle pressure on the cord to facilitate the full expulsion, but they shouldn't put any undue tension on the cord, because that can actually lead to problems with hemorrhage, and it can actually lead to involution of the uterus and damage to the uterus. That can be a medical emergency. So fourth is the stabilization of the woman and monitoring the initial postpartum assessment. Then after They're going to continue to assess, do the nursing management during this whole process, assisting with vaginal exams, monitoring uterine contractions, doing Leopold maneuvers where we feel the back, the bottom, and make sure that the head is down. We can feel the position of the baby in the uterus, in the abdomen. And there's also maneuvers that they can do to help facilitate the positioning of the baby too. But the Leopold maneuvers are just feeling for the smooth backside of the baby. And then you can feel the like hands and feet and that the head is down and ready for delivery. You want to make sure that you're assessing the amniotic fluid when the membranes rupture. It should be clear. So if you have any meconium, which is stool that the infant would expel in the amniotic fluid, or if it's cloudy or odorous and inside appears infected, that would be really important because we would be really concerned about neonatal sepsis. And looking for the fetal heart rate during this whole process. With contractions, there's ways to do internal and external fetal monitoring. External is with a belt over the woman's abdomen that senses the contractions in the fetal heart rate. So if you have variable accelerations and decelerations, as the uterus contracts, there's going to be some impairment of circulation to the baby, and there'll be a little bit of a decel in the baby's heart rate. But as soon as that contraction starts to release, that heart rate should come right back up, right? What's really dangerous is when the uterus contracts, cuts off circulation, the baby's heart rate stays down and there's a late decel and the baby's heart rate stays down. That means the baby's in distress, and they'll look at doing interventions then to help maintain perfusion to the fetus. And sometimes it means then taking that mother to an emergency cesarean section. So this slide kind of explains what is normal in terms of decels and fetal heart rate. So looking at the baseline rate of the baby being 110 to 161 beats per minute in utero, and the variability, having accelerations. So we want absent, late, or variable deceleration. So we don't want to see decels that aren't related to contractions either. That would indicate alterations in perfusion to the baby, blood circulation to the baby. So early decels could be present or absent. But so category 1, category 2, and category 3. So and just think that some of you might be going into the clinical setting tomorrow and seeing a baby get born. Wouldn't that be fun? I don't know about you guys, but I remember like being a student, and granted I was 18, 19 when I started going to clinical, and when I saw my first baby born, sure enough, like my thought was, oh my gosh, that's really how babies are born. That's how babies are born. But when you see it for the first time, it's like, this is really how babies are born. I just kind of had to laugh at myself thinking that. So this kind of shows what the rhythm strips would look like for, the different kinds of decels that you could see on the monitoring strip. So I talked about the belt for the external monitoring. And then for internal monitoring, they can actually put a little lead into the scalp of the baby for the baby monitoring. So some of the interventions then in terms of nursing management, of course, pain is a big issue. If the woman wants an epidural, breathing and focusing on, a focal point and doing relaxation, diversion, massage, repositioning is really important. Continually assessing the heart rate and any bleeding, providing culturally competent care, taking into consideration who the family wants in the room, who they want involved in the birthing process, and then care of the newborn too. Supporting the mother in feeding, choices. We want to support and encourage breastfeeding because breast is best in terms of best nutrition for the baby and providing some passive immunity, and having nutrition that's most easily digestible for the infant, unless they have a lactose intolerance. So we do support breastfeeding and providing breastfeeding education for all moms who want it, but then not being judgmental of mothers who do choose formula or bottle feeding. So this kind of shows those changes postpartum and how the uterus goes back to normal size from the umbilicus, and how it will go down. So there's changes postpartum in the reproductive system, cardiovascular in terms of decreased blood circulating volume, the urinary system. There can be, the pelvic floor can kind of stretch out, and the really multi-parous women who have had a lot of babies, they're more at risk for having some urinary incontinence. So teaching your Kegels, right? So we can all sit here and kind of do our Kegels now that we're thinking about it, strengthen our pelvic floor. GI, they may be taking pain medication, but also from the swelling that goes on from delivering the baby, constipation can be a really big problem. Musculoskeletal changes, integumentary, respiratory, endocrine, all those things postpartum also, as everything returns back to normal. Involution of the uterus involves 3 retrogressive processes: contraction of muscle fibers to reduce those previously stretched during pregnancy, catabolism, which shrinks enlarged individual myometrium cells, and regeneration of uterine epithelium from the lower layer of the decidua after the upper layers have been sloughed off and shed during lochia discharge. So the lochia postpartum progresses in 3 different stages. Oh yeah, and then, with breast is best too. So there's this golden hour. So we want to make sure that that first hour after the mom delivers the baby, that the baby's present with the mother. It used to be that we would take the baby to the nursery and monitor the baby for hypoglycemia and temperature changes and any respiratory distress right away. But now they keep the baby with the mother so that there's that attachment. But it means that the nurse has to be vigilant and has to monitor too, because sometimes these women are just exhausted. If they've had a prolonged delivery or if they've had medications, they could fall asleep. So, making sure that the baby's safe, the mother's not going to fall asleep holding the baby, so do keep your eyes on. And we talk about showing the baby like right away, and having the mom being able to hold the baby and everything, but you do have to watch it. And then there's some really cute pictures in your book too of this face-to-face with the mother. A lot of times as the mom is taking in this newborn baby, you'll see them actually touching the nose, they do this, and they're bonding. They're looking, they might be counting the fingers and counting the toes, and this is all normal part of that, taking in. And then after they've done this bonding process, this letting go is then they're able to they'll be all focused on that newborn baby. And then as they're letting go, it doesn't mean they're really letting go of the baby, right? But what they're doing then is they're able to focus on other people in the room, and allow other people to kind of come into that intimate mom-baby bonding situation. Then they can kind of like interact with visitors and partners and things in the room. So there's also behaviors that the partner goes through too, as they look at what were their expectations of their role, and then what's the reality. And as they are learning their role and learning those, the care of that newborn and everything, transitioning to where they feel like they've mastered this new parent role. Okay, so some of the nursing management postpartum, and your first sim in lab is this postpartum hemorrhage sim. So you'll learn in lab about some of the risk factors of postpartum hemorrhage, and we'll talk about that next week. I kind of segue this from here's kind of the normal parts of reproduction, and then we're going to move into with all this. Isn't it amazing when you start looking at this, that any baby is born normal, that things, like things actually go right most of the time. But what happens when it doesn't go right, right? What happens when there's alterations in this? And so we'll cover those alterations in reproduction next week. But some of those danger signs postpartum, right? If there's poor parent-infant bonding, we want to address that right away. Moms can have mood swings, and it can lead to severe postpartum depression, right? There's cultural considerations also. But we do want to make sure that that it's not like an abusive relationship too. So danger signs: fever in the mother, fever in the baby, lochia, bleeding, postpartum bleeding that smells foul or large clots. There's a certain smell to postpartum bleeding. I used to joke about, because peds nurses, we don't necessarily like to go floating to mom baby. And I swear, this is true, okay? Most of the time when I floated to mom baby was on a holiday, because they'd call out on the holiday. I don't know why. I was always, on St. Patrick's Day, I took care of the oh, what were they? The O'Malley twins or something like the Sullivan twins, Patrick and Ian Sullivan, and then I actually took care of Jesus on Christmas, right? And it was every holiday, and it was these cute names too. I had a thing going for a while. So I would joke about having to float to Lochia land. So when you guys are over there on the mom baby unit, and the bathroom, when you're monitoring eyes and nose and stuff, you'll just laugh to yourself when you think about floating, working in Lochia land. Medical humor. So, but with blood pressure changes in the woman, this is a big danger sign. We'll talk about preeclampsia, eclampsia, and these eclamptic changes can happen after they deliver the baby, also postpartum. So if they have severe headache, they start to see spots or have vision changes, blurry vision, we're very concerned about eclampsia. Calf pain, of course, DVTs, right? Swelling of the episiotomy, it can be a discomfort, but they can also have problems with their incision. So doing those sitz baths and encouraging comfort measures and ice and cooling pads for the mom. If they have burning on urination, making sure they're not developing a UTI. And then of course, monitoring for postpartum depression. Normal baby blues, they're gonna have some changes in hormones. But if it stays or if it's severe, whoops, go back. Okay, so one thing that's different in the mom baby world is there's this acronym bubbly. And on your clinical paperwork, do you have a second page for the mom baby area that has this bubbly acronym on it? I didn't see it in the paperwork, which is interesting because you guys are going to mom baby area, right? What, do you know what? Yeah. So you should have this on that assessment page. I wonder if that was an oversight.
Paperwork. It's not on there.
What's that?
It's not on there because I go to mom and baby tomorrow and it's not on there.
I'm gonna email Ms. Edwards, okay? Because now that I'm looking at this, there's a second page that's OB paperwork, where you're supposed to assess the breast, the uterus, because it's all about fundal massage. Your book has a really good picture of how you need to support the lower segment of the uterus, and then you massage. You can actually, like, when you feel your nose, this is how a firm cervix feels, okay? So normally the uterus starts returning to size postpartum. And as you're massaging, you're gonna feel something that feels very much like the tip of your nose when you're feeling the top of that fundus. And you wanna massage it till firm. So your nose is like how it will feel when it's firm. If it's boggy and you really can't feel it, you need to really deep massage, and the massage will help firm it up. Just like massaging a muscle, you don't want to massage the uterus for too long, for like not more than 10 minutes, 15 minutes, because the muscle will get fatigued and they can actually have more hemorrhaging. But if you have more than a quarter size, I forget now what I'd have to look at the blood, the amount of blood on their peri-pad per hour. And if they're having too much bleeding, you want to massage that fundus till firm. Assessing their bladder, making sure that they're voiding completely and that they're not retaining urine in the bladder post voids, and if they need to be straight cathed. Bowel, because constipation can be a huge problem. Looking at the lochia. So the lochia postpartum goes from lochia rubra is bright red. So lochia rubra is a deep red mixture of mucus, tissue debris, and blood that occurs for the first 3 to 4 days after birth. As the uterine bleeding subsides, it becomes paler and more serous, more of a yellowish. Lochia serosa is the second stage. It's pinkish brown and it's expelled 3 to 10 days postpartum. Lochia serosa primarily contains white blood cells, leukocytes, decidual tissue, red blood cells, and serous fluid. Lochia alba is the final stage. The discharge is creamy white or light brown and consists of leukocytes, decidual tissue, and reduced fluid content. And it occurs from days 10 to 14, but it can last 3 to 6 weeks postpartum in some women and still be considered normal up to 14. If there's a change and they start to have lochia rubra postpartum or at home, then you're concerned about uterine fragments. Part of the trying to think of the word, the placental fragments being attached, and that they need to go in and have like a DNC and have that removed. Okay, so cardiovascular system undergoes dramatic changes after birth. You have to watch for hematomas along in the episiotomy area. So they can actually, the hematomas can collect a lot of blood and can be quite large. So if they do have a large hematoma collection of blood in the perineal area, notifying the physician of that. Watch for any, if they've had an epidural, what is the their sensation, the circulation, sensation, and movement to the lower extremities. Sometimes after an epidural, they can have trouble ambulating initially, but it should resolve with time. So bubbly stands for breast, uterus, bladder, and bowel, lochia, the bleeding, postpartum. Episiotomy or epidural or extremities. So in terms of circulation, sensation, and movement. And then with episiotomy, you're looking at redness and edema and ecchymosis, or if there's any hematoma along there. If there's any drainage or discharge, any signs of infection on the episiotomy, and if it's well approximated and the sutures are intact and how it's healing. And then the final E is the emotional status of the mother. Is she bonding well to the infant? Is there any signs of any postpartum depression? She might be a little teary and stuff. Some of that's just emotional. Sometimes they're happy tears, okay? Sometimes they might be feeling a little overwhelmed with everything and just exhausted. So just providing that emotional support. Hannah, any questions or comments? No?
No.
Okay. Some NANDAs, some appropriate priority NANDAs would be readiness for enhanced childbearing process, right? And the definition of that is that pattern of preparing for and maintaining that healthy pregnancy, that childbirth process, learning to care for a newborn. Deficient knowledge regarding whatever area of pregnancy that they're in, and just related to whatever specific topic that you need to teach, if it's breastfeeding, if it's diet, nutrition. So interventions then would be the comfort measures, assisting with elimination, providing activity, rest, and exercise, preventing stress incontinence during pregnancy and after, teaching Kegel exercises, self-care measures for the mother, ensuring safety, teaching breastfeeding support, and discharge education. When are they going to follow up? All the newborn kind of discharge teaching. Dressing the baby like they're dressed. Like you don't want to overdress the baby and make the baby too hot. So we teach them to dress the baby as, to the level of clothing that they're wearing. How to care for the umbilical cord. How to watch for jaundice and changes in, skin color of the baby. When they're going to follow up with their pediatrician, when they're going to follow up with their OB doctor. Watching for signs of bleeding, abnormal bleeding in the mom. Fever, depression, right? And then evaluating. So having them teach back. Okay. So it's 1:45. It's kind of, I can show you these videos. and I'll post them. Because I really, really like them. And like I said, what's really cute is how they each have a different name. Into this one. Like possibly preggers.
EPCO educational topic number 10, antepartum care.
Just so you know, we can just see your.
I know. I got smart on one of the breaks. I went and did my laptop so I can see what you're seeing. There. Okay. And action. Like I said, I'll post the links in Blackboard so you can watch these on your own. Take notes when you do, because what I like is it concisely gives you each point of each different time in pregnancy, that what you need to know and assess.
Antepartum care refers to care before labor and delivery and begins with the first prenatal visit. Women who receive antepartum care during the first trimester have better pregnancy outcomes. Meet our patient, Newly Preggers. In this video, we will follow Newly's journey through antepartum care. The objectives of this video are to diagnose pregnancy, to assess risk factors for pregnancy complications, including screening for intimate partner violence, to describe appropriate diagnostic studies and their timing for a normal pregnancy, to list the nutritional needs of pregnant women, and to identify adverse effects of drugs and the environment on pregnancy. To perform a physical examination on an obstetric patient, to discuss answers to commonly asked questions concerning pregnancy, labor, and delivery, to describe approaches to assessing the following: fetal well-being, fetal growth, amniotic fluid volume, fetal lung maturity, and to describe the impact of pregnancy on medical problems and the impact of medical problems on pregnancy. Newly has regular 28-day cycles and she has just missed a period. Most women will take a home pregnancy test. How sensitive is a home pregnancy test? It becomes positive with a beta-HCG as low as 25. Newly may notice symptoms such as fatigue, nausea, vomiting, and breast tenderness early in pregnancy. For low-risk women, the first prenatal visit will be an intake visit at 6 to 8 weeks, followed by her first prenatal visit before 12 weeks. What are the goals of prenatal care? Early and continuing risk assessment, health promotion, medical and psychosocial intervention and follow-up. At the time of Newly's first prenatal visit, a comprehensive history will be performed. Special attention will be paid to chronic medical issues, past pregnancies and their outcomes, gynecologic issues, genetic screening issues, and social history. Smoking during pregnancy has well-known risks including miscarriage, placental abruption, fetal growth restriction, preterm delivery, birth defects, and sudden infant death syndrome. Alcohol is a known teratogen. Alcohol consumption during pregnancy is a leading preventable cause of mental retardation, developmental delay, and birth defects in the fetus. Other important issues to discuss are drugs, environmental and health hazards, domestic violence which occurs with high prevalence during pregnancy, and seatbelt use. One of the most important aspects of the first prenatal visit is establishment of the estimated date of delivery. Remember that we use gestational age that starts on the first day of her last menstrual period. The estimated date of delivery, or EDD, is calculated as 40 weeks past the LMP if she has regular 28-day cycles. Vaginal ultrasound can be used to determine the EDD if the patient's cycles are irregular, or to confirm the EDD if the patient's cycles are regular. Since Newly is a normal, low-risk pregnancy, she will be seen at 4-week intervals until 28 weeks, then every 2 weeks until 36 weeks, then every week until delivery. During each of these visits, she will have a weight, blood pressure, and fetal assessment. For diabetes screening, there will be a 1-hour glucose tolerance test between 24 and 28 weeks to screen for gestational diabetes. For obese women, the diabetes screening should occur at the initial prenatal visit. How do we monitor the fetus during Newly's pregnancy? Fetal heart rate can be verified with a Doppler device starting at about 12 weeks. Chromosomal screening provides the probability of chromosomal abnormalities. The first trimester screen provides the probability of trisomy 21 and trisomy 18. It is performed between 10 and 13 weeks. It is an ultrasound assessment of the nuchal translucency and a maternal serum test of PAP-A and free beta HCG. Alternatively, maternal serum screening also provides probabilities of chromosomal abnormalities. This is performed between 15 and 20 weeks. The triple test consists of alpha fetal protein, estriol, and HCG, and the quad test consists of alpha fetal protein, estriol, HCG, and inhibin. The fetal survey ultrasound is performed between approximately 18 to 20 weeks. If we are especially concerned about the fetus for conditions such as maternal diabetes, hypertension, or fetal growth restriction, then we will monitor the fetus more closely with non-stress tests. The non-stress test measures fetal heart rate, patterns, and accelerations by an external transducer for at least 20 minutes. It is considered reactive if there are at least 2 accelerations over the 20-minute period. Maternal kick counts are a way for Newly to reassure herself of fetal well-being. Starting at around 32 weeks, if she is concerned about decreased fetal movement, then she should lay on her side and she should feel 5 movements in 1 hour or 10 movements in 2 hours. Let's now move to fetal growth. The most commonly used assessment of growth is fundal height measurement. This measures the distance from the pubic symphysis to the top of the fundus. The fundal height measurement is approximately the number of weeks gestation. Amniotic fluid volume is assessed with an amniotic fluid index. This is a 4-quadrant assessment of amniotic fluid pockets. Decreased amniotic fluid is secondary to the fetus shunting blood away from the kidneys to the brain, which leads to decreased urine output. Let's now talk about fetal lung maturity. The respiratory system is the last fetal system to mature functionally, and if Newly has to be delivered preterm, then it can be sometimes helpful to assess fetal lung maturity. This is done by sampling her amniotic fluid through an amniocentesis procedure and checking for markers of lung maturity. What are Newly's unique nutritional needs during pregnancy? For folic acid, she should take at least 0.4 milligrams of folic acid daily, starting around the time of conception, and this significantly reduces the risk of neural tube defects. If she's had a pregnancy affected by a neural tube defect, then she should take 4 grams of folic acid daily. Excessive weight gain during pregnancy leads to an increased risk of pregnancy complications such as fetal macrosomia. It significantly also increases the risk of postpartum obesity. Weight gain recommendations are based on pre-pregnancy BMI. For a pre-pregnancy BMI of less than 19.8, the weight gain recommendation is 28 to 40 pounds. For 19.8 to 26, recommended is 25 to 35 pounds. For 26 to 29, it is 15 to 25 pounds. And if the pre-pregnancy BMI is greater than 29 pounds, the recommended weight gain is 11 to 20 pounds. Alternatively, inadequate weight gain in pregnancy is associated with preterm delivery, intrauterine growth restriction, and low birth weight. There are also foods with specific risks during pregnancy. Unpasteurized milk and dairy products and cold lunch meats could potentially carry listeriosis, which causes an increased risk of intrauterine fetal demise. Fish is a great source of omega-3 oils. However, large fish such as tuna, shark, and king mackerel have a higher mercury content because they eat the smaller fish and should be avoided during pregnancy. Herbal remedies are not regulated, and therefore pregnant women should be counseled to consider avoiding them. Moving on to frequently asked questions. Can Newly exercise during pregnancy? Yes. She should avoid exercises that carry risks of falling or abdominal trauma, and she probably shouldn't start any new strenuous exercises during pregnancy that she did not partake in pre-pregnancy. Can Newly have sex? Yes, unless she has conditions such as placenta previa or premature rupture of membranes. She and her partner will likely need to work together to find positions that are more comfortable during pregnancy. Can Newly travel? Yes. Most airlines allow travel up to 36 weeks. Have her avoid long periods of prolonged sitting and have her walk every 1 to 2 hours to promote circulation. Remind Newly of the importance of seatbelts worn low on her hip bones. Should Newly expose herself to teratogens during pregnancy? No, there are very few medications that are proven human teratogens. Common ones to avoid are ACE inhibitors, Coumadin, and isotretinoin. For ionizing radiation, it is recommended to limit exposure of the fetus to less than 5 rads. A CT scan of the abdomen and pelvis has approximately 3.5 rads. A CT scan of the head is approximately less than 1 rad. An abdominal X-ray is 100 to 200 millirads, and a chest X-ray is 0.02 to 0.07 millirads. We have covered quite a bit during Newly's journey through antepartum care. We have discussed pregnancy-specific needs and considerations and ways of assessing fetal well-being and addressed frequently asked questions.
So you know I'm from Michigan, so that's why I guess that's why I like that American College of Gynecological Care. So those, I think those are really good videos. So I really want you to spend some time watching each of them on the prenatal, antepartum, postpartum. I'll post the links in Blackboard. There's also going to be prep use on all these chapters. So I'll get those opened right after class and you can get to them. I'll also post the exam study guide. Okay, so I'll get that as soon as I have it finished. I'll post it early. So because the exam's going to be week 3, so it's going to be coming up quick. The semester is going to fly by. It really will. We've got the stuff on, you know, on pregnancy, the neonatal care, then pediatric care, and we get into the alterations with, you know, menopause and BPH with the male and female at the end of reproduction ages, and then we get into the mobility alterations and psych, and you know, finish up with Lou Gehrig's disease, Huntington's disease, Parkinson's, and then we're done. It like goes by. So I mean that's, you know, 15 weeks of boom, boom, boom. So, but look at all that you've learned today. Did you learn a lot just today? So, but it's fun stuff, isn't it? It's gonna be fun. It's gonna be fun going to clinical tomorrow. You gotta get to it. Okay, so prep use, study guide. No project this week. Next week I'll have an individual assignment. I'll give you each an exemplar, whether it's placental previa or, you know, some of the other alterations, and you'll do like a little care plan kind of thing that you'll post in Blackboard. Any other questions about anything? Okay. Okay, well, thank you. I'm ready for another fun semester.
Thank you, Miss Erickson.
Thank you.
Thank you.
Thank you.
You guys are a great class. Look forward to this semester.
Miss Erickson.
Yes, hi, Michelle.
A question.
Yeah.
So my exemplar for my preclinical paperwork is like nuchal cord or something.
Nuchal cord?
Yes. I can't find anything about it in the books or Lippincott. So I don't know if I just have to Google it for this like specific one.
What kind, is it nuchal cord rigidity?
No, just nuchal cord.
Just nuchal cord.
Mm-hmm.
Well, that's the umbilical cord, right?
Yeah. So from what I understand, it's the umbilical cord wrapping around the baby.
Like that's what I would think is issues with the nuchal cord. Yeah.
Mm-hmm.
Like nuchal cord prolapse, or all aspects of it. Okay, so just kind of maybe. Yeah. Maybe if you look up nuchal cord prolapse, so that means when the umbilical cord comes out before the baby, which can lead to, you know, problems with that being, or rigidity, like if there's not good perfusion to the baby because the nuchal cord, because of hypertension and things that can cause damage to the umbilical cord.
So, but as far as I know, it doesn't have any of that in the book. It like doesn't even mention anything about nuchal cord unless I'm missing it.
Mm-hmm.
And I can reach out to my clinical instructor too. You know what? But I figured I would see you first.
Umbilical cord prolapse is in here.
Okay. So maybe if I just go that route.
You could email her and say, if I do the patho on umbilical cord prolapse and the issues that can happen interpartum, you know, antepartum, right? Or interpartum, actually, when mom's delivering. Yeah. So I would just look up umbilical cord, not necessarily nuchal cord.
Okay. Because I tried umbilical cord and I was like, I don't know which way she wants to go about this.
Right.
Whereas everything else is like easy. It's like my next one's like gestational diabetes and like Alzheimer's. So I was like, okay, well, those are much easier things to find information about.
Good. Yeah, and actually when I looked this up with umbilical cord prolapse, it doesn't really say a lot. It just says that it could lead, you know, there's surgical methods and things if it, you know. Because I was thinking about positioning, getting the mom way over on the left side, you know, to help perfusion and Hmm. I'm wondering about factors. Like with prenatal with pregnancy-induced hypertension, how that can change.
Yeah.
So there's a whole section on 824 on umbilical cord prolapse, page 824, and we're going to cover that. But there's just a little bit section on patho.
Yeah, it sounds like I might have to use a little bit of a Google, because I tried looking in the like journals and stuff on the library, and it's not like super helpful.
Right.
Either. So I'll email her and see which way she would specifically like me to go, or if it's just going to be a little combination of like everything.
Right, because I hate to tell you, oh, just do this and lead you off, on something that she wasn't expecting. So.
Well, I mean, the preclinical stuff is only still 5 points, right?
Yeah.
So.
True. And it's week 1, so,
Yeah, but I got that dang math test that I failed the first 2, so I'm trying to get all the points because I'm already
those
in
point, yeah,
point place for the first couple.
That hurts, okay.
Yeah, there's enough to, I think, build it back up. So I'll be okay.
At least you passed it the 3rd time.
Yes. Yes.
Okay.
If not, we would be doing our NUR class for 2nd semester again.
I know, we got a few that are doing that.
Yeah, I know.
Your class got a little bit smaller, didn't it?
I know. It's sad, but they'll all get it. We'll all get it.
Right.
Eventually.
Yep. Things happen,
Yeah.
So, yeah, I'm sorry I can't be more help.
No, it's okay. I'll email her and see which way she would like me to go so that I can get started on it, because it's a full APA paper.
Yeah.
However I choose to make it.
Yeah, I think she's probably just looking for issues that can happen to it being insufficient, like nuchal cord issues and problems with the nuchal cord. And circulation, like the patho, so alterations in perfusion to the baby.
Yeah.
And what
so,
you would do.
And stuff to the baby.
Exactly. Like the D cells and stuff. If it's becoming, pinched, with prolapse. Yeah. Okay.
So I'm super nervous about tomorrow.
Oh, me too. What is it with this anxiety? Is it just
I don't know. I just feel like because we didn't have clinicals last semester that maybe we're not as prepared. Just like, how do I talk to people? I know how to talk to people, but I don't know. It's just a whole new environment for me. So I don't know. I'm just like, do I know what I'm doing? I'm hoping I just get to watch a baby being born because I'm labor and delivery tomorrow. So
people at TMC are really nice. And
That's good.
I've had really good experiences with them being good with students. So hopefully the stress of the pandemic hasn't changed that.
No, hopefully.
And if it does, we'll just be understanding of it, right?
Yeah.
And we'll just be there to help in whatever way we can. So
yes. So I think I know how to like follow people and just do what I'm told, and hopefully
we'll just be brave. It's another new, right?
Yeah.
New experiences.
I'm just excited, but I'm very nervous. But I know like my like little friend group who's all doing clinicals tomorrow is super nervous about it too. So we'll see. We'll make it through.
Yeah, we got you guys too.
Yeah.
Just your instructor will be there. We'll be there.
I don't know my instructor too.
I know. I don't know her either. I'll meet her in the morning.
Yes.
Yeah, I'm sure she's nervous too because she's going to be starting.
Yeah.
So we'll get through it. It's good. It's good that, hey, I'm glad, right?
I'm glad we get to see real people instead of doing VSIMs, because I like VSIMs, but they're like very safe.
Right.
So.
And that's the other part of it, right? Is we'll have to make sure we got our masks on, and I'm always harping on you guys, don't touch your face.
Yeah.
Now I mean it. Don't touch your face. Okay, we'll see you in the morning.
Yes.
Take care.
Bye. Thank you.
Thank you.